The second part of the afternoon, that's session 3, is entitled Cancer Treatment and Surveillance. I'm Lowell Schnipper, and I'm going to start off, and then we have quite a few talks about 4 or 5 more after me, and then hopefully a spirited discussion. So the specific commentaries for this afternoon's session will really begin to get down into the essentials of how the rubber meets the road in cancer care. And one of the things that we will be speaking about now, and something that's been alluded to earlier, is the Choosing Wisely campaign and ASCO's role in identifying a so-called top 5. A little bit of background is in order. In 2007, ASCO formulated a task force on the cost of cancer care, and I've been honored to chair that task force along with quite a few distinguished colleagues from oncology, economics, general medicine, industry. And we set out initially, probably being as horrified as everybody else, at the inexorably rising cost curve of American healthcare in general, understanding that the cancer equation is an important element within that. And the task force initially produced a guideline statement that was meant to essentially provide an understanding, as best we can arrive at it, of the problems in the cost of cancer care, namely, what are the drivers? We arrived at the obvious ones that many of you are aware of, which have to do with rising costs associated with the technologies that we employ to treat patients, the drugs we use to attempt to heal, the physicians and the patients, and our very, very complex interactions, and of course the payers have a role, all of them. We set out with one initial principle that actually was a bit of running against the grain, and that was a strong recommendation that as part of the routine interaction between a physician and his or her patient, that cost be factored into the equation, that this is a realistic, practical, and exceptionally important means of conveying not only our thoughtful recommendations as to how to deal with a problem that's life-threatening, but in addition, how to avoid or at least help deal with a form of toxicity that we don't usually characterize in our clinical research, i.e. financial toxicity, which we know is a growing problem among patients and their families. But in the deliberations of the task force, as we began to evolve and following publication of the statement on the cost of cancer care, we began to wonder, well, what is it that ASCO would do well to get behind? And many of us, being proponents of and contributors to the guidelines process of either ASCO itself or NCCN or other groups, understood that there is an enormous amount of clinical practice that goes well beyond the guidelines, in fact, at times runs counter to it. So we began to ruminate about what is it that we ought to best advise. And we began to focus on the possibilities that one thing that the oncology community is likely to get behind is the idea that useless or no evidence-based value associated with care ought to be something that we recommend doing away with. I have a couple of slides that are the obligatory cost slides that have been shown already in one form or another, but this is something that actually postdated the ASCO task force's formation, but it's from a recent JNCI paper that Robin, I think, was alluding to, or at least some of the work therein, which articulates in bar form breast, colorectal, lung, lymphoma, and prostate cancers at initial, post-initial treatment, and last year of life expenditures. And this is cost in billions, and as you can see, there is an enormous increase in most of these categories, particularly the end of life category associated with many of these illnesses. That's the dark bar, projecting expenses, keeping most things such as rates of discovery and the availability of technologies constant, as I understand it. But an enormous expenditure that's likely to rise. We've heard that as a rather constant theme throughout. And digging somewhat more deeply in the large compendium from Lancet Oncology that Jeff Peppercorn alluded to a bit earlier, using, for example, breast cancer as one focal point, when one looks at increased use of primary care modality, primary care of breast cancer that is, radiation and chemotherapy usage has increased tremendously, almost doubling, and the cost of chemotherapy has increased pari passu with that. Of course, with the employment of, for example, newer therapies, there may well be higher cure rates, particularly in the adjuvant setting, and we really find it difficult to understand the downstream implications of any of these. But suffice it to say that for the common types of cancer, the costs, the expenses are rising inexorably, along with new innovations, but the extent to which they really make meaningful impact is not always clear. Now, we saw this earlier as well. The task force, in thinking about what is it that the oncologic community should do, began to focus on that which is in the doctor's control. And indeed, we've heard dizzyingly complicated socio-political and economic arguments this morning. The system seems to be running amok, out of control, and very, very vigorous attempts are being made to try to kind of constrain it, with uncertain outcomes. But we indeed recognize that there are an enormous array of interventions that we are responsible for, an array of interventions that have little or no benefit, an array of interventions that sometimes are so toxic that despite a positive signal vis-a-vis a disease-based endpoint, patients just are reluctant or don't want them or are quite fearful of them, let alone the enormous problems that are generated by the duplicative nature of our current healthcare system. Varied EMRs, varied ways in which patients traffic between one group and another group, constantly repeating that which has been already done. So that sort of is the background by which we felt the one thing that we could, at least as a professional organization, begin to tackle in a substantial way is that which is under the doc's control. Now, we were motivated in a positive sense by Howard Brody's piece, as many of you must have seen in the New England Journal of Medicine. He wrote this, just to put it in its proper context, at a point in which the Affordable Health Care Act was under consideration in Congress. There was lots of verbal parrying back and forth, and that's an understatement, as you remember. But it was interesting because he pointed out in his perspectives piece that many of the participants, including, for example, the insurance industry, the pharma industry, were all basically seeing some positives in moving into and working with the genesis of the Affordable Care Act. But he pointed out that to his level of understanding at the time of writing, organized medicine was silent. That indeed, that organized medicine, steeped in a system that we all know and have critiqued this morning and this afternoon, a fee for service, the doctors were really silent. And he felt that this was almost a moral, or was in fact a moral issue, but certainly a potentially very, very valuable financial issue. He guesstimated that if indeed all medical specialties made a resolve to just simply stop doing what they felt was understood to be useless based on the lack of any evidence for utility, there's an opportunity for billions and billions of dollars. I don't know if it reaches the trillion mark. Zeke will have to tell me that, but it's like a big number. So Mark Twain, he quoted, said the following: "Always do right. This is going to gratify some and astonish the rest." And indeed, I think he was speaking about us, his own medical community. And indeed, we decided that it was a morally appropriate as well as a professionally solid thing to do to begin to construct a list of oncology practices that we felt didn't legitimately need to be done. So you've seen them before. They were alluded to in Scott's remarks earlier in the day. We identified 5. There were others that came up, and if some conversation permits afterward, I'm happy to discuss a few of them that we rejected, but may yet live again to fight another day. But the one that we sort of led off with was the idea of limiting the utility, of limiting the implementation of cancer-directed therapy at a particular point in a patient's life when it's pretty clear that most experts and most experts would agree it's likely to be useless. The next focused on imaging, or the next several focused on imaging. We've heard some about this. There have been numbers of papers written specifically looking at breast, at prostate cancer, and we decided to address this despite the fact that not every medical oncologist is responsible for pulling the trigger on this particular set of imaging studies. Although as cancer becomes analyzed and evaluated in multidisciplinary clinical contexts, it's very likely that these types of discussions will be had before the patient is necessarily put through the workup mill. But we felt it important to articulate that for low-stage prostate cancer, fancy and very highly sensitive and very, very costly imaging need not be done in those patients who are deemed to be at low risk for the existence of concurrent metastatic disease at the time of the disease presentation. The very same or analogous consideration applies to another extremely common human malignancy, and that is breast cancer. Again, there is, and there has been, there is now to this day an enormous overuse of PET scanning, of CT scanning, of bone scanning in low stage, highly unlikely to develop to have metastatic disease breast cancer patients. And related, but in some ways quite different because it goes on for years and years, a practice developed, somebody alluded to it earlier, maybe Zeke did when he was giving his remarks about training up in Boston, that patients who were treated ostensibly for cure with breast cancer would be seen repetitively for markers and for a variety of imaging studies. We felt we needed to deal with this because there's ample evidence to date that this offers no value. And the last of the 5 relates to colony-stimulating factors or the use of cytokines. Otis Brawley referred to erythropoietin. Here, we're actually speaking of granulocyte colony-stimulating factor, which at times is an absolutely life-enhancing modality, but far more importantly in this context is the fact that it's really misused, overused, and frankly sometimes underused. Now, how did we arrive at these top 5? Well, we truthfully did not perform a plebiscite for the entire ASCO membership. That would be about 10,000 individuals. But what we did, since we had a very large and representative task force, is to generate ideas from this group and refine them within the group and then expand it to individuals composing the clinical practice committee, as well as state state cancer organizations affiliated with ASCO. We distributed these to advocates, anticipating correctly that this is going to be a very, very sensitive arena. And we also, of course, then funneled all of what we brought in to the ASCO Executive Committee. So the representative population, not enormous, was about 200 physicians in all. I'm going to run through these quickly just to annotate a few of the points because it gives you an idea of what our thinking is, and as we hopefully expand this principle, and as other medical specialties expand this principle, I think that it may be useful. So the one guiding principle that we insisted upon is that we could find pretty much widely agreed upon objective evidence that what we were saying ought not be done is at least agreed to by a panel of experts. So for example, and so what I've shown here are a few slides, one for each of these 5, because we did an education and session at the recent ASCO meeting. And so 5 of my colleagues, each of them taking one of these, expanded in terms of the available supportive data to take home the point that we're not speaking lightly or anecdotally here, that this is all resting on pretty solid evidence. So this is from Tom Smith. It's a composite of a slide or two that he put together, but it basically makes the point that you've heard over and over again, and that addresses we need to do much better about end-of-life care when it's pretty apparent to the doc, sometimes but not always to the patient, that that which we direct at the cancer is not likely to have any useful clinical outcome. And it's generally speaking for those patients who are pretty much in bed or in a chair for more than half their day. Tom advocates just asking them if they can walk into the office, because if they can't, it's not likely we're going to do much good. Now, this particular one of the top 5, not so surprisingly, cost me a lot of Pepsid. I've had to use a lot, got a lot of heartburn, because this one reaches across the entirety of the cancer universe, and it's not disease specific. So what are the exceptions? In fact, should there be? And of course there are some exceptions. One, when we sent the top 5 out to many in the ASCO community, I got a couple of very pointed letters back, one coming from somebody who represents a biotechnology company that specifically has in its workflow mutational analysis. And so the question was, gee, are you going to say that somebody who's ill but has suddenly been found to have an activating mutation in gene X should not get drug Y? And of course that's not the intent. And indeed, if there is an available target for which we have credible evidence that if you hit the target, you're going to score at least a single or a double, a reasonable base hit in baseball metaphor, then yeah, go to it all the more. But that at the moment represents an infinitely small population compared to the group that we're really dealing with. And what all of this really emphasizes is the absolute need to address the palliative care issue, pari passu, while we're caring for somebody who's ill with cancer. And hopefully, the more oncologists adopt this particular mantra, the more they will indeed have built palliative care into their clinical paradigm as they care for somebody who doesn't need hospice care at the moment, but in fact is looking to the time when they might. Now, we spoke about imaging in breast and prostate cancer. The bottom line is that for low-stage patients, meaning patients certainly with DCIS or stage 1 and 2 disease, who are free of any symptoms that might be referable to disseminated disease. So there has to be a patient who's essentially asymptomatic from the point of view of this illness. It doesn't really help anybody, except, of course, those collecting revenues for the tests to do these imaging studies. It just doesn't help because not uncommonly you'll find stuff that requires follow-up that essentially will create morbidity where none was necessary. This is something very difficult to talk to women about when they come absolutely frozen with anxiety, as many of you know, and yet it's essential and it's extremely reasonable. Now, low-stage prostate cancer. I don't want to get into the intricacies of who should get the PSA or not, but let's just assume we encounter somebody who has a small volume of disease, as best one can tell, a low-ish Gleason score under 6, a PSA that's also low, under 10. This is a subset of patients with extremely small chance that they're going to have simultaneously presenting metastatic disease. Imaging, again, is wasteful, unnecessary, likely to turn up problems that never needed to be identified in the first place. We're suggesting strongly that this be done away with. And this by Patty Gans, who spoke to this particular one, and that has to do with following patients post-primary therapy, meaning, i.e., we hope possibly curative therapy for low-stage breast cancer. These are not the most recent trials, and that represents, I guess, a soft spot in the argument, but several prospective randomized trials failed to demonstrate any benefit accrued to individuals who were being followed by tumor markers and serial bone scans, for example, serial chest x-rays, in the context of and compared with just physician exam and annual mammography when following up an asymptomatic patient who has been treated in the past for breast cancer. So, and I emphasize asymptomatic because certainly the woman who comes in describing something that could be related to her underlying disease sometime in the past needs a whole level of different type of thinking. And so the qualification here is that indeed, and those who are skeptical do raise the point, well, what if we were to use more sensitive scanning techniques such as those we have today? Would that make any difference? The answer is we have no evidence that it will. In developing this as one of ASCO's top 5, I called, I wouldn't want to say every, because that would leave someone out, but I called many of the individuals who were identified by most of us as breast cancer thought leaders, and to the person, they felt that routine screening in the patient previously treated with curative intent is essentially not a useful, in fact, a valueless proposition. So here we again worry a lot about false positives and whether or not we're going to make more trouble than resolve by doing this. And lastly, this is Terry Mulvey's comments, or at least an aggregation of some of the comments that she presented at the national meeting a few months ago, having to do with the use of granulocyte colony stimulating factor. And here there is a very, very clear set of guidelines. They're basically promulgated right over here in the sense that it's meant to be used when the risk of fever neutropenia is greater than 20% with the particular regimen the patient is scheduled to receive. Now, what's interesting is that CMS did a study to look at the adherence to guidelines and the utilization of GCSFs in clinical practice. What was really interesting is that there was probably 17, 18, 19% overuse or inappropriate use as defined by the guideline I just alluded to, but there was also some underuse. So we not only have a problem of overzealous utilization of a technology, we have an educational issue because we need to educate docs as to when it is optimal to use them. Now, this 20% figure is not meant to be carved in marble. It's actually flexible because if an individual is under 65 but has comorbidities, diabetes, you name it, and you feel they are vulnerable with respect to the cytotoxic therapy that's planned, it's quite reasonable to utilize these. And so we've incorporated a number of caveats to make clear that there are exceptions. Now, the stakeholders' reaction to these have been kind of interesting and for the most part quite supportive, making me think that there is a genuine resonance with what we're trying to do and that it has the possibility of being expanded in a meaningful way. Some of my physician colleagues at various meetings have come up to me and said, thank you so much for what you guys at ASCO are doing. I found it helpful in the exam room when I'm talking to somebody who is not likely to benefit from care because of what stage in their illness they're at. Using something like this seemed to provide some additional measure of credibility to the suggestion that this particular physician was making. An NPR reporter called me up to speak about these when they first were presented as part of the ABIM's Choosing Wisely campaign. And the first thing he said was, does this mean grandma can't get her last shot? And I said, and the answer is, of course not. It's the kind of reflex reaction that so many people have, and he understood that indeed that is the reflex reaction. And therefore, it's going to require so much effort on the doc's part to literally sit with a patient and family and explain in some very, very caring and careful way why the answer is this is not a time for active cancer therapy. I had to appear before the Leadership Council of a variety of advocate organizations once the Choosing Wisely campaign surfaced. They had known about this because we had shared some of our top 5 list with them. But there was an extremely thoughtful, very, very courteously stated, but unambiguously skeptical concern about this by our patients. And I really resonate to that. Every one of us in this room is a physician who's been in a tough spot with patients who are in an even tougher spot than we're in. And it takes a lot of delicacy to get the message across that we indeed are now thinking globally, not just for all of society, but indeed for them and their families. The payers have been supportive in general, but not specifically rendering any particular critiques one way or the other. And I've heard, as I mentioned before, anecdotes or two from individuals in biotechnology wanting to make sure that ASCO is not walking away from targeted therapy, even late in the disease. Well, where do we go from here? Lesson number 1, we need metrics. We believe that in addition to comments about payment structures and incentives, we believe that docs are inherently wanting to do the right thing and mildly competitive. And those two characteristics, we think, can be utilized to achieve our ends. So at the University of Michigan, and this comes from a colleague, Doug Blaney, who, when he was as the clinical director in that cancer center, noticed that half the patients were getting chemotherapy at the University of Michigan within the last couple of weeks of life. What they insisted upon was adhering more closely to what were evolving as contemporary guidelines for exactly what not to do, realizing that they were traveling upstream on this one. So by insisting on documentation of performance status in the chart, and by teaching exactly what the guidelines suggest we do, in that organization, they were able to decrease in a relatively short period of time that particular practice, which in essence, if you remember, is consistent with one of our top 5, suggesting that if we can measure and demonstrate the data back to those whose practice patterns are being measured, we have an opportunity to influence behavior, even independent of the financial incentives that we probably do need as well. Now, ASCO has a very, very broad-based quality oncology practice initiative that many of you are familiar with. We are undergoing a process at this point in time in which we are in the process of incorporating the top 5 variables into variables that are going to be measured ad seriatim in upcoming audits of charts. All to the good, because it will give us an opportunity to get a measure of those COPE practices and their conformance to these particular elements, and also, over time, give us an opportunity to notice change, if any. And here's the problem. The problem is COPE penetrates a relatively small fraction of U.S. oncology programs to date, or offices to date. I don't know how many, probably 7.5%, 10%, but certainly not by any means half or more than half. We need to basically get data on larger numbers of physicians practicing in their own environments. COPE can do that. The other thing is that many of the COPE certified practices, that participate in COPE and a few are certified, certification implies a much higher level of functioning. These practices, by and large, are out in the community, and not all that many are in the academic medical center, where we are training doctors and teaching them professional habits for today and tomorrow. The University of Michigan, I believe, is COPE certified. My own institution just became COPE certified. I believe the Dana-Farber is in the process of becoming COPE certified, and I strongly advise and hope that other academic programs will do the same, because I think that will give us a reasonable measure of what's going on in those institutions, and it will influence those graduating from those institutions in a big way. ASCO has a rapid learning initiative that called CancerLink that many of you know of, and its whole raison d'etre is to provide an enormous amount of data from the oncology community at large that is readily analyzable and available for our understanding of, for example, how much does a clinical trial using disease X and drug Y, how faithful is the result in the real world to the result reported in the JCO? In other words, we need to know if our research, in fact, is really meaningful to the broad-based population, not selected for treatment X or Y based upon very, very strict eligibility criteria. We need to know what practices are happening in the offices across the U.S. The Rapid Learning Initiative actually gives us that possibility once formed. At its inception, our task force recognized that we need to reach out to the patients. They are our partners. And indeed, Diane Blum, a member of the task force who spearheads the Cancer.net program, Diane actually adapted from a prior IOM report a tremendous amount of information that has to do with cost and cancer care, and basically put it into very digestible form in pamphlet and web-based versions for patients to gain access to. It's been extremely popular, and its whole purpose is to, in fact, encourage patients to ask what the evidence is for the recommendation they're receiving, and to give patients the courage to ask us what the implications financially as well as medically are going to be for their particular interaction with the healthcare system over their cancer. The task force has written widely in a number of specialty journals about our work, be they in article form or a variety of commentaries. We've had regular presentations at the annual meeting and will continue to do so. And an initiative that we're just rolling out is something called the Physician Advisory Tool. A speaker earlier in the day actually demonstrated, I think it was Vina, who demonstrated that, made the point that a variety of treatment combinations for gastric cancer, as I remember, had a humongous difference in cost based upon the particular regimens, with relatively little difference in progression-free survival or overall survival or toxicity. We think that's a very important concept to bring right up close and personal to the practicing oncologist. And as a result, we're doing a pilot project in which we are making available to physicians participating a button on their computer desktop that will get them into a particular regimen for a particular disease, give them that regimen's endpoints, progression-free or overall survival, that regimen's toxicity, and the cost of each of the regimens. And what we'd like to understand is whether, in looking at that information, docs are in fact being guided towards particular decisions. So that's really a work in progress. And my last slide really speaks to moving towards a rational payment system that clearly is being called for by speakers throughout the day. One that ASCO, I think, is extremely sensitive to and endorses, at least endorses the search for. One that emphasizes quality, one that frees us from misalignment in terms of incentives for how we behave, meaning we need to redefine exactly that which motivates us. for delivering the highest value care, and that, of course, is going to be the best outcome for our patients for the least possible cost. And again, a concept that I know is being considered by many groups, but the oncology home is sort of as an extension or an outgrowth of the medical home, recognizing that the oncologist is a physician overseeing an enormous complexity of care and care decisions. Not all that different, but in a more focused disease base than is the internal medicine home. And this represents, I think, something to work towards as we think about how to organize cancer care away from the large medical centers when possible, and in fact, to reallocate the responsibilities for care, but organize them in a synchronized way that provides for the best outcomes for our patients. I'm going to stop here and move on to the next speaker in the interest of time. And the next speaker is, if I can get my glasses on, I'll get it. Deb Schrag from the Dana-Farber. Deb is going to talk to us about biologics and pharmacologics.
Good afternoon. Thank you to the Academy organizers and Dr. Shi and Dr. Gans especially. I want a special thank you. I've known Patty a long time, Dr. Gans, and she's never given up on this issue. So really appreciate her for her leadership over many years on this topic. So I've cut out a lot of data slides to eliminate some overlap from some of the other sessions this morning, and I've left in what I hope will be some provocative remarks so we can have a lively panel discussion. I've been tasked with talking about specifically chemotherapy and biologic therapy and what we can do to try to cope with high costs in this arena. So we're all clear about the goal. We want to save, extend, and improve lives. We want to cut costs. We want to drive innovation, and we want to maximize value. What strategies do we need to pursue to get there? How are we going to do this? Well, I'm going to emphasize 4 interrelated strategies. I think you've heard about these before. They've been mentioned by Dr. McClellan and many of the other speakers. I think that what we have to focus on is ongoing investment in better evidence, building the evidence base, and that means more research. We also need a lot more communication, education, teamwork, and coordination. We need to completely realign incentives and really focus on value-based benefit design. A lot of the comments you've heard about our broken fee-for-service system. And finally, insurance reform. So I also want to express optimism. It's really getting better and better to be an oncologist. We don't just have doxorubicin and cisplatin. On this slide are a list of the drugs. It's October. It's barely October. These are the drugs that have been FDA approved since January. This is incredible. They're really hard to say, but on this list, so I just like to say them because their names are so cool. Axitinib, pertuzumab, Ziv aflibercept. You may wonder why Ziv aflibercept? Because regular aflibercept is for the eye. It's a special ophthalmologic, so the Ziv had to get added. Isn't that cool? I'm going to give you Ziv aflibercept. It goes by the name Zaltrap. Vismodegib. I think you could probably, Vismodegib. Carfilzomib. Enzalutamide. Basatinib. Regorafenib. I mean, it's fun just to read them. Okay, and these drugs are for lots of new indications. Some of them are for indications where we had no treatment before. So Vismodegib, there's probably somebody who discovered this in their lab in the audience, and please correct me if I'm pronouncing it wrong, but this is for basal cell carcinoma, not a randomized trial. This is an orphan condition, people with really awful genetic conditions where they have basal cells all over their body. I mean, this is great that finally we have something to offer these folks. There are a couple of home runs on this slide. Pertuzumab, metastatic breast cancer, improvement in median progression-free survival of 6 months. That's a lot. Median progression-free survival of 6 months, that's a lot. Enzalutamide in the New England Journal of Medicine, I think, 2 weeks ago? Also just about 5.5, 6 months. Would we like to see a year, 2 years? Would we like drugs to cure cancer? Yes. but 6 months that's real. That's substantial. Yes, we also have drugs that we've FDA approved for what we can call very, very tiny incremental benefits. I happen to be a colorectal cancer doctor, and 2 of the drugs on this slide, aflibercept and regorafenib, are newly approved for treatment of metastatic colorectal cancer, and I'm having non-stop conversations when I go to clinic about if, when, and how we're going to use these treatments. Both of these drugs have black box warnings, lots of toxicities. This is not easy. So you probably can guess the next slide. Now I've put the costs, okay? This is, my red book, back of the 70-kilogram person, approximate, sometimes 28-day, 30-day cycles, but this is about what a month of these treatments costs. And it's kind of interesting. I mean, you'd think that these drugs were like sheep, that they all cost $10,000. It strains credulity that these would all cost $10,000. Some of them, we know drugs get developed by serendipity. Some of them take years. Some of them are just take sorafenib and stick another little hydroxide moiety onto it, and then give it a new name. But for whatever reason, they all seem to have a very similar price. And, the question is, how is it that this comes to be? We also know that these drugs are very profitable, and that's a good thing. As our presidential candidate likes to say, there is nothing wrong with making a profit. This is regorafenib. It's that 6-week improvement in median survival colorectal cancer drug made by a company called Onyx. And you can see that actually, if you go back a year ago, the stock was under $20. This was not a way to get rich. But I think it's from yesterday. I did this last night on Yahoo. October 5th, it was about $90 a share. So drug development is good for our economy. It makes money. It's great to do that. It's just a little problematic when healthcare costs potentially are sinking the rest of the economy. So what's going on? What are some of the problems here? Well, I think as we all know, the sellers establish and maintain the drug prices, and the rest of us don't really have an opportunity to object. Why is this? Well, for one thing, historically, there were often a very limited number of products for any single indication. So a particular drug pretty much cornered the market. There just wasn't a lot of competition. Obviously, we could spend an entire day just talking about our patent protection system and how strong it is and why we have it in place to continue to drive innovation. We also have cross-subsidization with the rest of the world. How many of you have been on a drug company website and seen those 2 flags? You know how there's the flag? The United States, click here. And then they usually show a German flag or a French flag, go here. It's like, we're not supposed to look in that curtain and they're not supposed to look in, it's different, right? So the companies have to make a profit, and they make their profit selling the drugs in the United States, as opposed to in other even highly developed and successful economies in Europe, where they do more price controls, and they have much better abilities to negotiate with the pharmaceutical companies. One of our problems that we still haven't fixed yet, those of you involved in healthcare reform, I guess this was an unsuccessful, maybe Dr. Emanuel would care to comment on this, byproduct of the healthcare reform, but our biggest payer, CMS, cannot negotiate. That's $10,000 a month? Okay. That's a problem. Oncology drugs are also in a protected special class. You may or may not know that I think 27 of our states, not only is there federal regulation, but there are state laws that say you cannot not cover them. So no insurance program, no insurance plan or provider can say, I'm not covering this class of drugs. So essentially the healthcare payers, maybe Dr. Newcomer or others could elaborate on this, they just don't want to go there because it's messy and sticky and difficult for them, and it's not worth it. But not to be all gloomy, I think a more competitive marketplace is emerging. So again, room for some optimism. When I trained in oncology, renal cell cancer, how do we treat renal cell cancer? We took some other drugs that worked in some other diseases, and we tried a little bit of this and a little bit of that, and it didn't really work. Well, since 2005, 7 drugs have been FDA approved for treating kidney cancer. That's incredible. We have choices: sorafenib, sunitinib, temsirolimus, everolimus, bev, pazopanib, and axitinib. Do we exactly know which one to use when? Are these home runs? Have we cured kidney cancer? No. Do we have a long way to go to work out the kinks? Absolutely. But now they're choices. And what does that mean? Well, it means we can do refining trials. It means that these drugs can compete against one another. And hopefully when there's more competition, we can drive the price down. But when you only have one drug to treat a disease, of course there's less competition. So I think having lots of drugs in a space, eventually we ought to reap some benefit for that. And of course we have to figure out as a community what to use when. But again, all of a sudden kidney cancer is looking like antidepressants or looking like H2 blockers. You know, you've worked in a system where you can only use Zofran, you can't have Kytril. Oh, nope, then I moved to another hospital, you got to use Kytril, you can't use Zofran. We're used to that kind of flexibility. Maybe we'll get there with kidney cancer drugs. Maybe not tomorrow, but I think it ought to be possible. So I think that there's some room for optimism. So I'd like to emphasize and underscore that I think that clinical trials remain the linchpin and the way forward, but we have to get more nimble and better at accrual. The numbers are still abysmal. For as long as I've been in oncology, it's been 2 or 3% of all patients go on a clinical trial. I've seen numbers that suggest it's even lower now. I mean, we just have to get better. We have to design studies with meaningful endpoints and effect sizes. 6 weeks, I mean, it is metastatic colorectal cancer. It is a treatment refractory population, but we've got to look for bigger benefits. We have to embed molecular correlatives so that we actually understand the mechanisms and what we're dealing with. Is that always possible? No. But do we really understand how bevacizumab works after all these years? Not clear to me that we would. Dr. Mendelsohn might be able to explain it to us. I think we have to distinguish when we look at our trials, when we do our trials, those that provide a little bit of incremental benefit for many people versus those that provide an enormous benefit for a very distinct subset. So for example, crizotinib, if it's 8% of all lung cancer, but people who have that particular molecular target or that particular mutation, they're going to get a huge benefit. That's really powerful. But then we need to figuring out who those folks are and doing the molecular profiling up front in a strategic way. So we only give the drug to the people who are going to benefit, and obviously the paradigm for that is KRAS testing in colorectal cancer, and now we give cetuximab to people who are much more likely to benefit. So there's progress. We've had some triumphs. We need a lot more. We can't only do drug company-sponsored research. We have to invest and curate our publicly funded clinical trial system. Why? Because we have to ask questions that say, can we do less of something? Not just can we do more. Pharmaceutical companies ask, can we do more? Can we add? Can we do new studies? But they don't say, can we do less? So I just want to give you an example, and this may sound just a little bit like whining, but I just have to share this anecdote. I'm the PI of a phase 3 NCI-sponsored clinical trial in rectal cancer that tries to say, can we retire pelvic radiation? We've been radiating patients with rectal cancer since the standard was set at an NIH conference in 1990. And since then, chemo's gotten better, surgery's gotten better, everything's gotten better. And we think that and imaging's gotten better, so we think we can actually do a study now where we select the patients and spare patients the misery of pelvic radiation. It's also hard to treat them when they recur because their bone marrow has been radiated. And this trial has been endorsed by every single cooperative group, including RTOG, SWOG, the Canadians, international groups. So I've been calling around to a couple of sites that have been sluggish about activating. Some of you may be from these institutions. So I get on the phone with the GI oncologist and I say, is it the surgeons? Is it the radiation oncologists? Why aren't you guys activating this trial? And they kind of stupidly say, you know, we lose money. It only reimburses $2,500 a patient. We're underwater. Our accountants won't let us because it's a money-losing operation. And they're like, yeah, we have a competitive trial. I'm like, you have a competitive trial? What's that trial doing? It's adding one of those IBs I showed you on the first trial to the radiation. It's like crizotinib, axitinib plus radiation. It's definitely, these are more of trials. And then I say, so what's the per case reimbursement? $24,000. So my phase 3 clinical trial funded by CTEP is competing against pharmaceutical-sponsored studies. That's a $20,000 difference for the cancer center, for the hospital. So, I mean, the cancer center would have to be nuts to want to put patients in federally sponsored trials. So what do these people say? And I know them. Some of them are running GI oncology. They're like, okay, Deb, we're going to pony up. We're going to put in 4 patients. That's what we can afford. We're going to put in 4 patients. I'm like, you are one of the largest cancer centers in the country where I used to work. You're going to put in 4 patients? I'm going to kill you. But sorry, Mary. And you know, these are my friends. Those are my friends who are putting in 4. Actually, those are co-investigators who are putting in 4. So it's a problem that I think we need to fix. There's this just huge gap between public and private, and we need a public system because you know what? When the pharmaceutical company trial says you need 12 months of a treatment, maybe 6 months is just as good. So we have to figure out a way to get those studies done. We have a lot of crosstalk between different federal agencies. I happen to work with many of them, CMS, FDA, CDC, AHRQ, and NCI. And boy, sometimes are they not rowing together. And I think, you know, it would be great if the research community, if we had more cooperation and coordination between them. And I think that is related to costs. I think we need to better align incentives to maximize value, as you've heard from earlier speakers. We have this funny alliance between pharmaceutical companies, physicians, and patients, and we're often squaring off against payers and taxpayers who are basically future patients. And we end up being sort of strange bedfellows and all kinds of unusual conflicts which crop up. And we work really hard to try to manage those, but they can be pernicious and crop up anyway. As oncologists, we're still paid at ASP plus 6. And as long as we're paid at ASP plus 6, giving the more expensive drug always gets us, or even if we're salaried, our cancer center, more money. And I think, as Dr. Emanuel said, we still earn a lot of money. There's the moral hazard of having health insurance itself. The vast majority of patients, and I think this is not true in the community, not just at a specialty cancer center where I work, have no skin in the game because our insurance system already is so good. For Medicare patients, 80% of them have Medigap policies. So we see on the front page of the paper these really unfortunate, horrible stories about medical bankruptcies and the people who are going broke and the people who don't have a Medigap, but it is a tiny minority. Most of our patients are immune to this. They're able to get these very expensive drugs without feeling any effect directly in their own pocket. So it's kind of the opposite of what we discussed this morning. It's also so much insurance that we're inured to it. We have, by and large, very generous policies, Medigap, Medicaid, caps, resulting in a pretty limited role for the patient assistance plans. It's really hard to get information as to how much actually the pharmaceutical companies spend on these patient assistance plans, and I'd be happy to debate that with someone. And as a result, all these high costs ultimately get passed on to employers, all of our employers, and ultimately to all of us as U.S. taxpayers. I like this article that appeared in April in the New York Times from Andrew Pollack, who's really a terrific reporter. And he was writing not about a cancer drug, but a hemophilia drug. And he profiled a kid who was sitting in his bedroom with all these empty vials of medicine. And his mom was saying, thank goodness our insurance covers all of this $100,000 a year drug. And his mom was talking about how scared she is that the insurance company would drop the coverage and she'd have this big copay and go bankrupt and sell the house and the farm and et cetera. As a result of this and fear about this, patients and patient advocates in many, many states all across the country have introduced bills into state legislatures that would limit out-of-pocket payments by consumers for expensive drugs in these 6 special protected classes. And guess who the biggest proponents of this legislation are? The pharmaceutical companies, of course, because the more that is paid for, they're still going to make a big profit as long as insurance pays. So this is an important issue that is in many of our state legislatures. I think we need to do better to align incentives to promote teamwork and coordination. If you give chemotherapy, you need a plan to minimize emergency department and hospitalization use afterwards. When I give my colorectal cancer patients a dose of irinotecan, if I rush through and I don't explain to them how to take Imodium and how to drink enough and what the phone number is to call, and if they speak Spanish and I'm rushing to get to an airplane, they're going to end up in the ER. And right now, I'm not on the hook for that. And when that has happened to me, almost all the time I look at myself and I was like, I was going too fast. I needed to slow down. I needed an extra half hour. They needed a phone call the next day. Most of those admissions, I know it. I know it. I have a small moment of guilt. I swallow hard. I say, I won't let that happen again. But there's no repercussions. I know it. It's me and my guilty conscience that someone ended up on the ER Saturday night with diarrhea that I could have prevented if I just slowed down a little bit or explained or got a better interpreter or something. But right now, I'm not on the hook for that. I think strategies that were discussed this morning in terms of value-based design and rewarding good behavior, incentivizing accessibility outside routine hours, communication strategies that include patient to clinician, clinician to clinician, hospital, home, patient care, waiting room, group education, and communication across different healthcare systems are all valuable strategies. In terms of fostering accountability, I think we can do a lot with value-based design, but we don't know exactly how to do it, and we're going to need a lot of experimentation to get there. Just as a simple thought exercise, what if each oncologist were profiled based on a panel of all the healthcare service utilization that was used by their patients within 30 days of administration of a dose of chemotherapy? Could we make this a win-win for patients and doctors? How to avoid emergency department visits and hospitalizations. Well, this is part of what Lowell spoke about in terms of the ASCO top 5. Don't treat people who shouldn't be treated. Communicate honestly about risks and benefits. Don't postpone difficult discussions. Be available off hours. Communicate, educate, and reinforce. And partner better with home care. We also can't abandon existing, simple, low-hanging fruit strategies to limit costs of these very expensive new drugs. Now that we have more choices within a particular therapeutic class, as I showed you for kidney cancer, more and more of these drugs are shifting from the medical component of an insurance benefit to the pharmacy benefit. And that means that we can use the traditional levers that you use for your antidepressants or your cholesterol drugs, things like tiered formularies, 1, 2, 3, most preferred, least preferred, step edits where the pharmacist says, no, you can't have that one. First, you got to try this drug. So it's sort of a turn back at the pharmacy. Prior authorization, yes, it's painful, but there is some evidence that it helps. Does it need to be better implemented so it's less painful? Absolutely. Quantity limits. Oral chemotherapy drugs that cost $10,000 a month can be dispensed in 2-week supplies. That's $5,000 worth of medicine. Yes, it's a pain to go back to the pharmacy and get more, but a lot of patients don't last 2 weeks on a particular drug. So just think, if we dispense 2 weeks at a time, I can't tell you how often a patient of mine dies and I get a little package with a thank you note, and usually in it are fentanyl patches and like 5 bottles of sorafenib. And I look at the sorafenib, and they got the sorafenib from Medco, and Medco gives you a 3-month supply. And they have a 3-month supply of sorafenib, and they took 2 weeks of it. And then they say, well, there's a sweet note, and it says, maybe somebody else could use this. And then I walk down to my pharmacy, and I say, see these fentanyl patches and lollipops, stuff for patients who are dying in this sorafenib. Can you take it? And they look at me, and they say, it's radioactive, it's illegal, you can't do that. And they take it, and they put it in the trash. And this happens all the time. So maybe other clinicians could comment, and I always take a deep breath and say, wow. Cost transparency was discussed by others. So what about treatment pathways and guidelines? Dr. Abernethy is going to talk about Compendia. Just a few comments. I think that these work best when there really is a menu of choices. Obviously, if you've got similar efficacy, and you can choose the least expensive option. But these pathways and guidelines are resource intensive to develop and curate. It's very challenging to keep them free from commercialism. I do think that one thing that is helping is chemotherapy order entry systems where the right regimens are hardwired in. It makes it easy for people to do the right thing and save money and be efficient at the same time. One thing that these systems are often missing are molecular profiling systems that go hand in hand. So when you order crizotinib, are you ordering it for someone? When you order trastuzumab or pertuzumab, is it for somebody who's HER2 positive? So we got to get that piece together, which is an IT issue, and obviously the IT systems need to be interoperable, and we need a real discussion about whether the extent to which they're proprietary versus open access. So just a word about comparative effectiveness research. It's a strategy, but it's not a solution. Obviously, we need to leverage our day-to-day experience and abundance unused data and system capacity, and the better health IT systems will facilitate that. I think it gives us a chance to examine the many patients who are left out of trials and the chance to examine the gap between how well treatment can work in the context of a research study and how well it does work in the context of day-to-day practice. But obviously to do it, we need a lot better data sets, more quickly and cheaply available, as well as better methods. And we also need to better engage our patients and manage conflicts, because comparative effectiveness research is subject to the same kinds of conflict issues that clinical trials are. I want to end by talking about what happens when we actually speak to patients and some of the challenges of informed decision-making about how to use cancer treatment. And I'm speaking more about advanced cancer treatment than, for example, adjuvant curative treatment. Most of the time, we're treating people for diseases that are life-threatening. And framing matters when people feel like they're really under the gun. But it's really hard for people to get information about treatment benefits. If you look at a drug label or you look at a consent form, there's lots of information about the risks, hair loss, nausea, vomiting, but the information about what you can expect the benefits are is a lot more opaque and difficult for people to follow. It's also hard for us as doctors to customize that information sometimes for the person in front of us who's got a little diabetes and a little heart disease and a little this and a little that. And we're also in the exam room, and we want to make our patients feel good. We want them to like us. We want them to feel comfortable. So even though we don't want to sugarcoat things, we want to tell people the truth, we also want to make them feel good. And sometimes that does mean that we put a positive spin on things. As part of CANCORS, and some of the CANCORS investigators are in this room, CANCORS was an NCI-funded multi-site population-based study that involved comprehensive surveys of patients undergoing chemotherapy, as well as abstraction of their medical records. And it included a really comprehensive telephone survey done about 4 months from diagnosis. So one of the things that this survey got at is, what are patients' expectations from chemotherapy? Are these expectations in line with reality? And what factors are associated with having realistic expectations? So this study is in press at the New England Journal. I'm going to talk about the sample. It included ultimately 710 patients with metastatic lung cancer and 483 with metastatic colorectal cancer, interviewed shortly after they had embarked on a course of chemotherapy. And this is what it showed. When patients were asked what their expectations were of the likelihood that chemotherapy will cure their cancer. Remember, these patients all had metastatic disease. Just about 35% of colorectal cancer patients and about 25% of lung cancer patients thought that chemotherapy was very likely to cure their cancer. And you can see the distributions on the slide. So clearly, our patients have an overestimate of how good treatment is. So I'm going to just skip through here. So we looked in multivariable analysis at the factors that were associated with an inaccurate response to question about the likelihood of cure for chemotherapy. And one of the most powerful factors was patients' perceptions about physician communication. When patients thought that their physicians were really good communicators, they were more likely to have the misperception. So it's the trade-off. You want to be liked, but your patient gets it wrong. You give the bad news, the patients rated the communication. So it's a tough one. I'm not sure how we're going to get our way out of that. What I think we need to do, I think we need to change the way we label chemotherapy treatment information. We need to think about revising consent forms with clear, simple, direct statements of the magnitude of benefit from these treatment, and we need to partner with our patients to figure out how to do this. So this is a personal viewpoint. These are what I think are some low yield strategies to control costs of care. I think that incorporating costs into discussions about advanced cancer treatment is almost dead on arrival. It's just really hard. It is so hard to do that. I think that completely eliminating patient accountability for cost sharing is also not good because it completely gets rid of the skin in the game. I think profiling individual providers, which has also been talked about, is also a relatively low yield strategy. Doesn't mean we shouldn't do these things at all. I just think that they're going to be low yield. I also think that in this country, the cost effectiveness, nice United Kingdom approach is not going to work. It's just not who we are in America. What are the leverage points? Getting our federal and state agencies to row together, curating, modernizing, and sustaining our cancer registry, investing in our clinical trials infrastructure, which is already pretty good. It just is a little starving. Requiring pharma to conduct follow-on trials, coverage with evidence development, engaging patients. We can do it. It's hard, but we really, really have to do it. Not like a nod, but really, really do it. Incentivizing clinicians to build the evidence base and simplifying the research data collection enterprise. So I'll stop there.
Thanks, Deb. We're going to move on to a discussion of Compendia. What drugs are reimbursed and what drugs aren't, and how do we determine that? That's Amy Abernethy from Duke.
Hello. So my name is Amy Abernethy, and today we're going to talk about the Compendia system, which really seems like it's a conversation around reimbursement, but I think it belies a much bigger issue. A day in the life. So this is a snapshot of November 16th, 2009, and I actually took this snapshot in preparation for a meeting that Zeke was putting on, and I thought to myself, I wonder how commonly I make these decisions about off-label prescribing. Sat down, and every patient that I saw, I actually pulled out and tried to figure out whether or not my decision was in line with the current FDA regulation. Half-day clinic, I saw 14 people, of which 4 were new patients, and there were off-label discussions and decisions in 8 of 14 patients. That's pretty substantive, a substantive proportion when I thought of myself as I'm an evidence-based practitioner and I know what I'm doing. And, you know, that day when I was at Zeke's meeting, I presented 4 cases, and in fact, they were cases 1, 2, 3, and 4, the first 4 people I saw in my day. And DD is an exemplar. She's 66. She's the wife and a caregiver of her elderly mother. She had developed melanoma on her right leg, had some groin adenopathy. At the time when she first presented to me, met the expectations for interferon therapy. FDA indicated, although we can all discuss whether or not interferon as adjuvant therapy makes sense, nonetheless, we decided not to do it because she wanted to take care of her mother, and we didn't think it was going to make it, she was going to be able to do so. She comes back now with metastatic disease, and we're trying to decide what to do. At that time, IL-2 was FDA indicated, and she was clearly not appropriate. She was BRAF negative, considered her for a clinical trial, but we weren't quite sure what to do, and in fact decided the first thing we should do was dacarbazine versus temozolomide. Temozolomide being essentially the oral option versus dacarbazine, where she was going to need to come back and forth about 3 hours to see me each time and still trying to take care of her mother. And in fact, I prescribed temozolomide off-label. Shame on me. Standing there that day, I was thinking to myself as I was making my little check boxes on my list, all right, now maybe I should just prescribe this dacarbazine. And then I thought, no, I'm not going to do this different from my current practice. So what I did was I spent more time thinking about what was my practice all about and why was I making the decisions I was making. And really I think this becomes the conversation of off-label prescribing in oncology, why we do it, what are the drivers and how we're going to make sense of it all, and where does the Compendia system as part of a reimbursement mechanism reinforce or help us make specific choices. So off-label prescribing is the prescription of pharmaceuticals for an unapproved indication, unapproved in the context of the regulatory authorities, and it may be an unapproved indication in the context of a particular disease, so head and neck cancer as opposed to pancreatic cancer, may be due to a different restriction, so for example, BRAF inhibition, or an unapproved age group, dose, or form of administration. It's common and expensive in oncology. So in 1991, the GAO reported that about a third of our drugs were being prescribed for off-label indications in oncology. And the current estimate is that it's somewhere right around 60 to 70% of all prescribing in the medical oncology space. That's a lot of drug. Some of the forces behind off-label prescribing are that of the clinical urgency as well as the biologic plausibility. It makes sense that this patient has evidence of HER2/neu, although it's not in breast cancer, and it might make sense to use this drug. There's also aggregating evidence that I may be aware of because I've been at ASCO where I've seen it in the latest issue of JCO, even though it's not necessarily made it to the FDA indication. Oftentimes, the regulatory decisions lag behind the evidence accumulation and what gets to the FDA, and maybe even specific indications will not be brought before the FDA or a non-US regulatory agency. And certainly then there's this issue of being reinforced by the payment system, as we'll talk about. There's also lots of forces hindering evidence development. Our ability within the context of the system to rely on phase 2 data, and what does that mean? The issues around rare diseases and how do we make sense of that within the context of where we put our resources in doing clinical trials. The lack of post-regulatory incentives and an uncoordinated situation in terms of data collection and cost. So as I was sitting there in that clinic that day, was the doctor the problem? I may have been. Certainly, one of the things we'll come back to at the end, really highlighted by Deb, is that these are doctors and patients making sense of the literature and the illness together and trying to make decisions at point of care. So at the end of the day, we move from a population-based question back to individual patients and doctors. But individual patients and doctors are trying to, and interacting with a very rapidly expanding system of data. So these are data that were presented at ASCO and this year and are currently under review. Essentially what we see is that across all clinical trials presented in clinicaltrials.gov, oncology represents the largest proportion of studies in clinicaltrials.gov, 88% of which are open and 64% of which are non-randomized. We compare that against the other therapeutic areas, and what we see is that oncology is much more likely to be open in early phase studies, 84% against the non-oncology space. So we've got lots of studies happening in the oncology space, many of which are early studies potentially contributing to our understanding of what may work for whom and when, but certainly not necessarily getting all the way to the point of FDA approval. Interestingly, though, we often have this sense in oncology, all that stuff that's going on, yeah, but it's really the novel stuff that hasn't even gotten to the point of really being ready to go to the FDA yet. So Deb has highlighted the story of renal cell a minute ago, and in fact what we did was we decided to take a look at the renal cell portfolio within clinicaltrials.gov, and what we see is that 2/3 of the studies presented in clinicaltrials.gov were around FDA non-improved indications for FDA-approved drugs. So 2/3 of the studies that were actually happening in this phase 2 space were indeed around off-label indications. So is the problem the evidence and or the sponsors or clinical research? Is that where the issue is going on? So now let's start taking a look at another part of the driver in the system. So clinicians need a method to make sense of rapidly accumulating evidence. We need this comparative effectiveness to decide what works between different choices. And meanwhile, I think there's a reimbursement situation that reinforces the approach. Now, before I get to the end and sort of my punchlines in the talk, I want to make sure that it's clear that I'm not advocating for or against the Compendia system as a particular reimbursement mechanism. In fact, I think that what happened was as the system was being developed, it seemed like the most practical solution to the big problem. So as a part of the Social Security Act, there was a decision to rely on the Compendia as authoritative mechanisms for the reimbursement of drugs in the off-label setting. Now, Importantly, the compendia were thought of to be essentially comprehensive resources about drugs and their evidence and the way that evidence lined up across different indications, across different modes of delivery, and different points in the illness trajectory. At the time when this started, 3 compendia were recognized by the legislation as being authoritative. The American Hospital Formulary Service Drug Information, or AHFS-DI is what we usually would call it, the AMA's drug eValves, and the USPDI. What happened over time was that the AMA drug eValves went away and the other 2 merged. And so that essentially, practically within this system, we had one compendium giving us advice about what was the appropriate indications in the off-label space. And based on that advice, a drug could be approved for reimbursement for use in the off-label setting. So one of the things that happened then was, as a part of a CMS and AHRQ program in the technology assessment area, we were asked to take a look at the previously available compendium, now drug points, which was the subsumed USPDI HFS-DI combination, versus the other compendia that were available as the pre-selected at the time. So we looked at drug decks, facts and comparisons, NCCN, and also in clinical pharmacology, and tried to understand what were the purposes of the compendia, what were they trying to do, and how good of a job were they able to do this in the terms of the role of off-label decision-making. One of the first things I think that was most important and instructive to us was when we asked the compendia, so what's your purpose? What are you here for? They said that the purpose was to guide the use of a drug prescribed, not to guide the choice of one drug compared to another drug. So in fact, the way the compendia have been structured and what they are supposed to be doing, despite the fact that we have put them in the role of helping us make decisions for off-label prescribing, that was not their purpose as they were previously stated, nor the purpose as it evolved over time. They talked to us about subjective processes for validity assessment, choice of citations, and the policy for equivocal evidence. What did they say or not say when the evidence was equivocal? Did they stay silent, etc.? And each had a different approach, and each said, you know, we're trying to figure out how to do this better, but we haven't figured this out. What they did talk to us a lot about was the fact that the evidence and the number of trials evolving in oncology is coming forth so quickly that it was hard to keep the monographs updated at any point in time, as I'll show you. So next thing we did on request from CMS was take a look at across 14 different drug disease indications. These were all off-label drug disease indications, and the reason why we chose them was there were combinations of old drugs plus new drugs, common or rare tumors, and essentially these were common indications that were being reimbursed at the CMS level in the off-label space. What you see here is if we look across the 5 different compendia, that essentially there was a variety in whether or not any one particular compendia included any conversation about that drug disease indication. So if we only had one compendia, it was dealer's choice as to whether or not it was dealer's choice as to whether or not that conversation around a drug disease indication was going to show up in the compendium. But if you had more compendia, you'd actually have a higher chance of at least having a review of that drug for that disease indication. We then decided to drill down further and try and understand what was going on in the context of one specific drug disease indication in the off-label space, gemcitabine for bladder cancer. We chose this because it was really the oldest combination in our list. There was the greatest amount of accumulating evidence, and one of the questions that we had was, since we are essentially starting to rely on the compendia system as our way of doing real-time comparative effectiveness research, was the compendia system able to keep up for us? So there were 43 published phase 1 to 3 studies around gemcitabine for bladder cancer in 2006 and 68 in 2008. And when we looked across the 5 different compendia that we were asked to review, what we saw was very different summaries in terms of the stage of cancer for treatment, metastatic versus non-metastatic, second line, third line, in terms of how they talked about treatment order, first line, second line, in terms of use of agent, whether or not it was monotherapy or in combination, so gemcitabine with other things. And the only thing that they all were consistent on, goes back to their purpose, was a conversation around toxicity of this particular drug in this particular indication. So in fact, we're relying on the Compendia system to help us essentially do comparative effectiveness research, but really their role still in their mind has been that of helping to understand toxicity around drugs and what does it mean once a drug has been prescribed. We then also looked to see what was happening in terms of the accumulation of evidence and how that was actually starting to show up within the Compendia system between 2006 and 2008. And DrugDex was the compendium that had the greatest accumulation of evidence being reported in its monograph between that period of time, and went from 3 citations to 11 citations in summarizing the literature in that change over 2 years. And as you'll recall, there was an additional 20 papers that were published in that 2-year period, going up to almost 70 papers of available citations in literature. So currently we rely on the Compendia for continuous systematic review, but is their task feasible? So the next thing we did was we were asked by CMS to do a systematic review using the AHRQ Evidence-Based Practice Center system versus the Compendia system. So we essentially looked at what the Compendia were doing versus what would normally be done in an AHRQ EPC summary. We looked only at targeted agents that were FDA approved and marketed before January of 2007, and this is the list of drugs for which we reviewed. Really what I want you to note is this slide. This summarizes it all in my mind. So between 2005 and 2009, this is just a count of the number of identified studies in the literature around each of these drugs in their off-label indications, alemtuzumab, bevacizumab, bortezomib, etc. And you can see all of these are going up across time. And if we take bortezomib as an exemplar, what we see is that there were 32 studies cited in 2005 for the off-label indications we were asked to review, and 137 in 2009. Each year accumulating a lot of studies, and whether or not these were meaningful studies, I'm not here to say, but certainly if you're going to ask the Compendia system to continuously do systematic review for you and make sense of it, we are asking them to make sense of this. Indeed, we saw a rapid accumulation of poor quality evidence, and the Compendia were trying to continuously do systematic reviews. For those of you who know me and were sort of part of my world during this time, I finally said, I quit. And I quit because I really couldn't make sense of it all, and I was actually supposed to be trained to do this. Meanwhile, the Compendia were actually trying to do it and still are trying to do this without a structured system to guide in the process. There are a large number of phase 2 trials. In fact, when we looked at this, we think many of the phase 2s were really case series, and there was this rapid publication cycle with what we called the June 5 effect. So there would be a rapid change post ASCO. So in fact, what happened in 2008 was because of the fact that we only had one real compendium on which we were relying prior to 2008, CMS and MedPAC made a decision to expand and add NCCN, ClinPharm, and DrugDex, try to expand our opportunity to make sure that we were able to keep up with this rapid accumulating evidence, but also said we really need to start thinking much more constructively about what we're going to do in our future, especially given the fact that this represents 2/3 of our prescribing in oncology. Observations from my point of view was that the evidence was accumulating fast and not designed for the task that we were asked, and the Compendia system was not designed for the task that we're asking it to do, and that yet this is how we reimburse many of our drugs. Is it the evidence we need? Is the Compendia CER reference? And should the Compendia system as a way of doing CER be linked to reimbursement are big questions we need to ask ourselves. And the perverse angle is that the chaos or the system developed to deal with it promotes indiscriminate prescribing and reimbursement back to the clinician level. Now, I can't spell, but is the problem the Compendia system and its influence on reimbursement? I think really what we're talking about is the wild, wild west, and part of the problem is we haven't actually demanded of ourselves that we figure out a way to make sense of it. To summarize, I think this is the world that we're currently living in evidence development and off-label oncology, where the quality of evidence on the x-axis, on the y-axis, and the evidence development over time is on the x-axis. And what you can see is when our predominant constituent is the FDA, or the group that we're trying to talk to in order to make sure that a drug gets approved is our regulatory authority, we very systematically push the evidence cycle forward. However, once we get past FDA approval, we end up in this area of uncoordinated case series, phase 2 trials, and occasional randomized trials with post-approval evidence development not being coordinated or systematic. And this, I think, takes us between the land of discovery and regulatory approval to that of comparative effectiveness with clinical decision-making by clinicians, patients, payers, and policymakers, and that's where we stand. And so for the last 2 minutes, I just want to talk to you about some potential ways forward. So this work then led to a series of projects trying to think about, now what do we do? Can't just say stop. So this is a substantial part of our practice. We could just say stop, but I think it would leave all of us sitting in clinic going, okay, now what? So in fact, one of the things that we've done is started to ask the question, how do we actually make better sense of the evidence in this space, and how do we do better trials? So one proposal going forward was that around essentially better approaches for pragmatic clinical trials in this space, and published in JCO back in January, the effectiveness development guideline to try and think about what should be the properties of pragmatic clinical trials in order to support our understanding in the off-label oncology space. This was done under the guidance of the Center for Medical Technology Policy, and akin to FDA guidelines, start to give us what's the structure for how to do these trials. Important features were real-world comparators, real-world populations, designing our outcomes carefully, incorporating biomarkers, and preparing for the biological sciences. Certainly, we've had in this room today and over time the conversation around learning healthcare, collecting the data at point of care to help us understand what's going on, so that ultimately, as we generate our evidence, we can make sure that it's pertinent in the context of the care of patients and the clinical decisions that we're making. And when we talked about rapid learning and learning healthcare, one of the critical use cases that's been put forward, Lynn Etheridge really, I think, was the first person who said this is one of our critical use cases, has been off-label oncology. And this was the New England Journal on Thursday. So France and their new framework for regulating off-label use in France, where they've developed this concept of temporary recommendations for use, or TRUs. I've been calling them TRUs, but I'm not sure what they're really supposed to be. And it's balancing the need for rapid access to drugs like we've got in oncology against this reality that it takes a long time to get regulatory approval, and sometimes regulatory approval may not be happening. And so putting in place a system of continuous evidence, or really data accumulation, as we move into the temporary recommendation for use space, so that we can monitor what happens in real-world practice and essentially start making rapid learning happen. And interestingly, when we look at this and we look in the New England Journal article, it points out that predominantly this is expected to happen in oncology, because it is one of the points here is around prognosis-associated diseases. So it's thought to be an approach that's going to be most used in oncology and hematology, as well as infectious diseases. So learning from other countries, and I think that's been a refrain from today, and an important refrain here. So my key messages as I depart: off-label prescribing oncology is a real part of what we do and a substantial cost of care. It's reimbursed with reinforcement through the Compendia system, and that's really our current reality. We can't just cut it off, or I think that it's dangerous to just cut it off, but we actually still need to make sense of it all and monitor what's happening in a way that we can ultimately generate evidence from our current practice, so that we can generate evidence to define appropriate off-label use in the future. Thank you.
We're going to switch gears entirely from drugs to RADs, and we're going to hear from Justin Bekelman at University of Pennsylvania, accountable care, or toward accountable care in radiation oncology.
Thanks, Lowell. Good afternoon. It's my privilege to speak with you today. It's also a real honor to be here on a panel with Dr. Schrag and Dr. Bach and Dr. Manuel, all of whom are mentors of mine, and so it's a real pleasure on multiple parts. My goal is to give you my views on 7 principles toward accountable care in radiation oncology, and I'll just start with some disclosures. So first, I'm a genital-urinary radiation oncologist at Penn and a health services researcher, and that means that I treat men with prostate cancer, but I also treat men with proton therapy. So that either makes me the most unpopular gentleman in the room, or given the age and Y chromosome of many of the folks in the room, maybe perhaps the most popular man in the room. In all seriousness, I treat with a gamut of technologies, and I also have a large active surveillance clinic. I'm also on the executive committee of the National Radiation Oncology Registry, which is sponsored by ASTRO and the Radiation Oncology Institute, and I should report to you that my views expressed here today do not represent those of ASTRO or the ROI. So let's begin with these 7 principles, and the first one that really must define how we're going to restructure in radiation oncology is this. Principle number 1, move beyond fee-for-service payments, separating cancer specialists' incomes from treatment choices. We've talked about that today, but we haven't thought about how that would actually work in radiation oncology, where there are both technical fees as well as professional fees. And in fact, in a course of radiotherapy, the technical fees, the fees that are paid to the owners of the equipment, really comprise a good 90% of what's reimbursed to the facility and to the physician. And oftentimes the physicians are not the owners of the equipment. In fact, the majority of cases, it's the hospital or the facility that is. So what does the current payment system cause? And I'll give you some data slides focused on radiation oncology because we haven't touched on them as much. On your left side is a figure that represents the virtual substitution of IMRT, of 3D conformal radiation for IMRT in prostate cancer over just a period of a few years. It's estimated between 2002 and 2005 that $1 billion of extra additional direct costs were associated with IMRT for prostate cancer. IMRT, needless to say, is reimbursed at a higher level than 3D conformal radiotherapy, and there was limited evidence to support its clinical superiority. But this isn't only within prostate cancer, it's also within breast cancer. On the other side is the FDA approval of a brachytherapy device for breast cancer with follow-on Medicare reimbursement, and of course, adoption happens. This is affected by reimbursement policy, understandably, and also by practice settings. So in these charts, I've looked at IMRT for breast cancer, and this is from the MD Anderson group. On this side over here, it shows in green those Medicare carriers whose local coverage determination was favorable. It means that medical carriers said, okay, we'll support IMRT for breast cancer. And then in the blue, it's those coverage areas that did not support, in other words, were unfavorable and explicitly said, we will not pay for IMRT for breast cancer. And of course, the adoption is differential depending on reimbursement policy. And that also holds on the other side here for hospital-based versus freestanding centers. And we're all aware of the differential reimbursement for a hospital-based facility versus a freestanding facility. And again, the adoption tracks. To follow on to Dr. Manuel's point earlier in the day, this fee-for-service system has unintended consequences. So in 2005, there was a randomized trial that showed that 1 fraction of radiotherapy was equivalent to 10 fractions of radiotherapy for uncomplicated bone metastases. When we looked at about 11,000 courses of radiotherapy among men with prostate cancer who had metastasized to the bone and then were treated with radiation, after the publication of this data, this is work we did over the summer, we found that literally less than a few percent are treating with a single fraction of radiation. It's as if the randomized trial did not exist, and shortly after the follow-on ASTRO guideline did not exist. In fact, it shows that the majority of cases are using greater than 10 fractions of radiotherapy for bone metastases. And again, we have the differential between freestanding and hospital-based outpatient centers. So what is the takeaway here? In order to stop this spiral, we have to sever the relationship between treatment choice and reimbursement for treatment. But that's complicated for radiotherapy because it involves both the physicians and it involves the hospital facilities and outpatient facilities as well that own the equipment. Second, align provider incentives toward patient-centric coordinated care among cancer specialists and PCPs. Why is that important to a radiation oncologist? Well, let's look at, again, prostate cancer, which is my area. What I've shown here is work from Michigan where the bottom axis is the portion of Medicare claims across different provider specialties, so the primary care, medical oncology, urology, radiation oncology, and then the left axis here is whether those claims were for prostate cancer or for non-prostate cancer, and this is among prostate cancer survivors within SEER Medicare. So what this shows is that nearly 50% of all claims amongst prostate cancer survivors are submitted by primary care physicians. It also shows that about 1/3 of claims are submitted by urologists, and that the urologists focused on prostate and the primary care docs focused on the comorbid illnesses, the non-prostate claims. But what about radiation oncology? Radiation oncology is a small portion of this. Radiation oncologists, understandably, are focused simply, in this case, on treatment. And so it means that after definitive treatment with radiotherapy, other docs are following these patients. And if there's no coordination between radiation oncologists and the urologists, the medical oncologists, and most importantly, the primary care physicians, then we are missing a huge part of the pie. Number 3, we have to link guideline concordant care to shared savings from global payments. We've had some talk about this today. It's my personal opinion that global payments are the most important type of payment reform beyond ACOs and beyond medical homes for oncology, and especially for radiation oncology. And let me give you 2 different ways to think about it. The first is modality-based payment, which would be a care pathway or a bundle payment for example, for uncomplicated bone metastasis. This is likely feasible. It's already happening across the United States in some pilot projects. It will likely result in important savings, but I would argue that it will have a limited impact on care coordination, and I will also argue that it will have a limited impact on the full picture of accountable care in cancer. Well, let's think about the alternative, diagnosis-based payments. For example, a global payment for localized prostate cancer. Shortly, Dr. Manuel and I will have an article where we propose a cancer care group, which is a diagnosis-based panel of surgical, radiation, and medical oncologists that is paid a global payment to provide care, but then also to coordinate with primary care. One would argue that this would have a greater impact on care coordination and linkage to primary care, but this is incredibly challenging to implement. And just think about prostate cancer. Who's the lead doctor? In medical oncology, admirably, medical oncologists have led the way in terms of cancer care groups or oncology medical homes, but medical oncologists are not as involved in localized prostate cancer, which is the predominant and prevalent form of prostate cancer today. So who's going to lead? Is it the urologist? Is it the radiation oncologist? Is it the primary care doc? If we get all these docs together, how do we pay them? I can understand how we pay them within an integrated clinic, but if we're trying to get them together across clinics in the community where most cancer care is delivered, we have to devise new payment scenarios to actually link payments to these and then provide some portion of it to primary care. Number 4. Provide feedback to patients, providers, and payers through population-based performance of care quality, outcomes, and costs. This is apple pie to all of us in the room, but let me just give my one provocative idea here, which is by our analysis, over the next decade, the federal government through the CDC will spend about $1 billion on state cancer registries, in other words, the registries that make up SEER. About $1 billion over the next decade. That's an incredible investment in cancer epidemiology. But because of the way the registries are formulated, it will lead to very little investment in accountable cancer care. So the question would be, can we upgrade federally supported state cancer registries to provide near real-time ascertainment of quality metrics, of risk-adjusted outcomes, and of costs by linking with claims databases? And this is beyond SEER Medicare, which for all intents and purposes today is an incredible tool, but it's a research tool. Number 5, address cancer specialists and hospital margins with transparency. This is critical. Why is this critical? Well, an underlying subtext of the literature that we read, even the discussions we've had today, is that high-quality specialists and facilities will retain their margins while the overall volume of services declines. That's the assumption. But when you go out into the community and when you talk about these reforms with physicians and with hospitals, it's not clear that they buy into that. And so we have to be transparent. Is that actually going to work? And note, I say, can high-quality specialists and facilities retain margins? Well, what about the other specialists? What's going to happen to them? So we have to be transparent for two reasons. First, it promotes market signaling to hospitals. And hospitals, we have to appreciate that whether you're a large hospital or you're a small hospital, a good portion of your bottom line comes from the technical fees from radiation oncology. And so when you think about transparency and market signaling, what that means is that you're telling hospitals to start thinking about how they're going to budget for the future. In addition, it signals to the radiation device industry that they have to, in addition to their bells and whistles machines, begin to market value-based technology, technology that deals with quality and safety, in addition to the bells and whistles that they're used to marketing right now, which leads us to the number 6. The sixth principle here for accountable care for radiation oncology is to incentivize the radiation device industry to invest in evidence generation alongside payers and alongside federal and non-federal funders. So this is a fundamental shift in the radiation device industry value proposition, and I'll tell you why. So if you look across the main sites here, prostate cancer, these are the prevalent sites, breast cancer, lung cancer, and you look at the comparisons of the new technology versus the other technology, whether it's IMRT versus non-IMRT or proton therapy versus not proton therapy. There's very little evidence showing a clinical superiority to the new technology. In fact, related to proton therapy, it's taken us many, many years, but I can report to you that we finally started a randomized trial. This is in partnership between the University of Pennsylvania and Mass General Hospital to compare proton therapy to IMRT for prostate cancer. We just started last month. We've actually randomized 5 patients. But to Dr. Schrag, if you will allow me a little bit of whining, it's taken us 3 or 4 years to obtain the funding to do it because the federal funders took a long time to be able to swallow the idea of comparing treatment A to treatment B within the National Cancer Institute. And to their credit, the National Cancer Institute is funding this trial. But to give you a sense of things, in one of the earlier reviews, one of the co-PIs of the trial, the reviewers questioned the trial on the basis that as a proton therapy center, we also treat with IMRT, we had a conflict of interest. Well, of course we do. We're using the treatment. Right? So it's very challenging to get these types of treatments done when there is so much suspicion around what they call for proton therapy, the Death Star of comparative effectiveness research. There's so much suspicion around this that we can't get the good research done. All that to say, equipment manufacturers need to have their skin into the game and be part of it. And so here I depict the R&D, the research and development spend of leading companies as a proportion of sales. And I'm comparing medical products companies to pharma or biotech. And so over here you see that on average the top quartile medical device industry companies spend about 10% of their sales in terms of research and development. And then if you look at pharma, it's about 30%. Well, why is that? It actually makes sense. Largely medical device companies are engineering companies. They have been engineering companies, and their job is to make great machines work better. But now it's different. They need to demonstrate the value of their machines, and what that means is that they need to invest through research and development in the clinical trials to demonstrate that value. And so if you look at Varian and Elekta, the two titans of radiotherapy device manufacturing, they are right in line with medical products companies in terms of R&D, but I question whether they should be more in line with pharmaceutical companies in demonstrating the value of their products. And number 7, related to this, is that if we do get the device industry and the payers and the federal government to fund the types of studies that we're looking for to demonstrate the value of the new technologies that are coming on board, we have to be willing to pay for the innovation, and that's about transparency. We have to be willing to pay for the innovation when the high-quality evidence development is conducted early in the product life cycle, and that's why this is a fundamental shift. And I'll just conclude with one somewhat out-of-the-box way of conceptualizing payment reform in radiation oncology specifically. So we need to explore differential reimbursement for treatment and coordination complexity. So if you look at this, what I've done, and this is totally illustrative, but it gives you a sense of a three-tiered system. You can have radiation complexity on this part of the 2x2 table, and then care coordination across the bottom. And each of the dollar signs represents a tier of reimbursement, let's say. And so you could probably put prostate proton therapy, prostate IMRT, breast 3D or IMRT down in this bottom quadrant. And then contrast that with pediatric proton therapy, which requires sometimes general anesthesia. This is a highly complex treatment that requires intense care coordination and a tremendous amount of resources to deliver what, for many kids, is an incredibly important, sometimes curative therapy for their tumors. And we have to think about radiation not as the blunt hammer that's been conceptualized as it before, but as part of the types of therapies that can be applied to different subgroups of patients based on the value of that treatment. Thank you very much. What I've presented today is 7 principles for accountable care. Happy to talk about it later.
Thank you. We're going to move to yet another technology, one that drew some comments from earlier today, the surgical treatment of cancer, and Jim Yu from the University of California will speak to that technology.
Thank you. Sure. It's a pleasure and a privilege to be here this afternoon. I'd like to thank Dr. Gans and Dr. Shi for the kind invitation. So I've been charged with talking about new technologies in surgery. And I'm going to use the robotic-assisted surgery, which, as mentioned earlier, has been widely discussed, as a case study. Disclosure, similar to Dr. Bekelman, I'm a practicing urologist, so I do use the technology. However, I don't receive any consulting fees. I do have funding from sources from the Department of Defense as well as the NCI. So our objectives are to describe the current environment of robotic surgery, discuss strategies to evaluate innovation in surgery which may not change clinical outcomes but increase costs, explore how we can evaluate whether there's evidence that expensive surgical technologies provide better outcomes for patients, and then discuss opportunities to attenuate the rising cost of oncological surgery. So I think first it's important to really understand what robotic surgery is and how it differs from traditional open and laparoscopic approaches. As many of you know, laparoscopy is simply using a light source and a camera through small incisions to look into the abdomen. This differs from the robotic approach, which is also a form of laparoscopic surgery, in the sense that there is a device that's going to be connected to these ports for minimally invasive surgery. And of course, one of the benefits of these smaller incisions is just less tension on the abdominal wall, less analgesic use, faster recovery. The robot is somewhat of a misnomer. It's computer-assisted surgery. It's not automated. However, this version of the robot costs $1.6 million. Intuitive Surgical is the monopoly manufacturer, recognizing that there's an importance to training. The next version is the dual console, which now costs $2.4 million. Of course, in this, you can't, with the older iteration, add the skill simulator, which costs another $100,000 to practice computerized simulation rather than on a live patient. And the next innovation in robotic surgery will be the use of a single port rather than multiple ports. So arguing for the use of robotic surgery Richard Satava is a leader in surgical technologies. He argues that you can do things with a robot that you can't do with a laparoscope, or only the world's best surgeons can do. It's a democratizing tool. And the main principle behind why with the robot you can do things you can't laparoscopically is the use of these wristed instruments, and I'm going to show you an example of that. In addition, there's the 12-time magnification of laparoscopy. There's ergonomic advantages for the surgeon, and compared to open surgery, we're pumping carbon dioxide into the abdomen to create exposure, which then tamponades venous bleeding. And so this figure just demonstrates, or this graphic demonstrates below the traditional laparoscopic scissors, and then the robotic scissors, which again has additional 2 degrees freedom of motion. Now, kind of in our theme of buying a car and adding options, there is on this newest model of the robot also fluorescent imaging for additional $100,000, which provides the ability to look at arterial blood flow. And this is helpful in situations of partial nephrectomy. This is a patient I operated on actually 3 weeks ago. Radio reporter that then broadcast a personal story shortly thereafter. So there we've put a arterial clamp on one of the 2 branches of the renal artery. And you can see here with all the evidence showing that partial nephrectomy is underutilized and that there's better overall mortality when partial versus radical nephrectomy is used. This then allows the surgeon to identify whether a mass is in the distribution of artery that can be selectively clamped versus decreasing the blood flow to the entire kidney, in the manner of saying that sparing every nephron counts and minimizing ischemia. The most recent FDA approval is for transoral surgery for benign and malignant tumors at the base of the throat. And you can see that conventional surgery required an ear-to-ear incision across the throat or splitting the jaw, and may have resulted in speech and swallowing deficits. Now, whether or not these innovations are worth the significant increase in cost remains to be determined. When we look at some evidence that favors robotic surgery, we had the chance to look at the nationwide inpatient sample in 2009, looking at radical cystectomy, for which there is a ongoing NCI-sponsored randomized controlled trial as well. And most significantly, we found that with the robotic surgery, there were no deaths compared to inpatient mortality of 2.5% for open surgery, which is in line with the traditional large series from USC, Memorial, and others. And I attribute this to the lower blood loss and lower likelihood of transfusion, the absence of volume shifts that occur during radical cystectomy, which is a very bloody procedure. Additionally, there was lower use of parenteral nutrition. However, when you look at the costs, it was about $4,000 more expensive than traditional open surgery. So the con is, of course, that of all the instruments and surgical tools that hospitals have adopted, this is one of the most expensive items in American operating rooms today, as Dr. McCary mentions in his book of Unaccountable, describing the healthcare culture and the runaway cost. This New England Journal article from 2010 also nicely illustrated the differences in costs between traditional open and robotic surgery. I put asterisks here because radical prostatectomy is the most common robotic surgery in cancer surgery listed here, and the green asterisks represent cholecystectomy and benign gynecological hysterectomies, which are the next targets for Intuitive Surgical, the device manufacturer, because as you can see, these numbers are several-fold larger than radical prostatectomy. And of course, the single port application may be applied to the cholecystectomies. As Barbosh et al. Notes in New England Journal of Medicine, robotic surgery adds about 13% to the cost of surgery. For prostate surgery, it appears that more men chose surgery with the robot than if the robot had not been offered. And the replacement of open with robotic surgeries and procedures where it's currently used will add $2.5 billion annually to the healthcare expenditures. These are the current FDA-approved robotic procedures. Again, in the nationwide inpatient sample in the last quarter of 2008, a robotic use modifier 17.4x was added so that on the inpatient side, one could distinguish when the robot was being used. And when we looked at this, we found that urologists, by and large, were the, if you will, the leading offenders of using this new technology, with robotic prostatectomy and partial nephrectomy being the most common. Gynecology was bringing up second place, and then the general surgeons had not yet a widely adopted use of the robotic surgery, nor had the head and neck surgeons. We can see that the Da Vinci surgical system has been widely installed since its FDA approval in 2000. There's about 1,450 sites in the United States which has a robot, and in some cases, up to 5 robots. We see the stock price here from its humble origins at FDA approval up to more recently over $500. This, for those who are correlating it with the Preventive Task Force recommendation, of course, came after the Grade D PSA recommendation that led to that may be associated with the drop in the stock price. When we look at marketing and media attention, Business Week was the first to describe the robotic surgery. Initially, the robot was intended to be used for cardiac surgery, but the CEO will say that intuitive shot for the heart and hit the prostate due to the high prevalence of prostate cancer. One of the early centers, as you saw in that graphic, was Henry Ford Hospital, and on their website, they used to say that the potency outcomes with our robotic surgery are the highest reported to date. Of the patients undergoing surgery, 97% achieved erection strong enough for intercourse, and argued that robotic surgery protects sexual function. Several years ago in U.S. News and World Report, the robot was the cover boy or girl, if you will, which in my mind synonymized quality of care with the adoption of new technologies such as robotic surgery. And the robot has been featured widely in media coverage in popular series such as Grey's Anatomy. Here we see our Commander-in-Chief contemplating healthcare reform while seated at the Da Vinci robot. And when we look at the public view of robotic surgery, in that same in a Newsweek article, it argued that robotic surgery compared to open had better cancer removal as well as lower complications, which at that time had yet to be shown. And of course, here next to Fenway Park is a advertisement for robotic surgery that's being broadcast to those who are on their way to the airport, perhaps. So again, case study of robotic radical prostatectomy. Several years ago, the New York Times published this article. This is a construction site for proton beam therapy, and argued that prostate cancer is a litmus test for healthcare reform, and that there are increasingly expensive treatment options with very mediocre outcomes. We looked at the SEER Medicare database and found that the adoption of IMRT and robotic surgery had led to an additional $350 million being spent on prostate cancer in 2005. And of course, this likely underrepresents the true amount of incremental costs, since Medicare's fees are much lower than private health plans. A systematic review of the cost of radical prostatectomy find that consistently it varies from $2,000 to $4,000 more than the traditional open approach. There's only one study that applied traditional health economic evaluation that found robotic surgery to be cost ineffective. However, those same investigators then showed that there was a quicker return to work, again in Scandinavian countries as a caveat, with robotic versus open surgery. And so I'd like to spend a couple of minutes just speaking about the nuances of radical prostatectomy, because I think it's very important to understand why it is difficult to use study designs like randomized controlled trials to evaluate new technologies in surgery. And so, of course, radical prostatectomy has been around for a long time. The Da Vinci robot was applied and was rapidly adopted. There's various surgeon volume outcome studies in which that basically when you control for the effect of hospital volume, surgeon volume is the main driver of outcomes, and we see this more and more today as length of stay has decreased from 7 days in the 1990s now to where it's a less than 24-hour hospital stay for robotic-assisted surgery. So for instance, in the cardiac literature where the hospital volume or the ICU nursing and support staff is important, or perfusionists in the OR are important for radical prostatectomy, that importance of hospital volume is less. And then when we looked at the influence of surgeon and hospital volume on radical prostatectomy costs, we saw that with higher hospital volume, regardless of cost, regardless of surgeon volume, costs were higher. And surgeon volume, the lower surgeon volume, tended to have lower cost. Now that may be explained, this of course was another study of SEER Medicare, but this may be explained by the fact that hospital mergers, such as the one that happened in Toledo, lead to higher reimbursements passed on to consumers as higher premiums, co-pays, and other costs. And another example of this, of course, comes from Partners Healthcare in Boston, where similar things occurred when the Attorney General investigated. So for surgeons, really, the challenge isn't so much, I think, rather for patients, the challenge isn't so much how to find the best robot, because there's only one manufacturer, but it's rather how to find the surgeon who can optimize the trifecta of outcomes of continence, potency, and cancer control. This new Wall Street Journal article from a decade ago spoke of a Medicare, rather a HMO beneficiary that wanted to leave his health plan to one of these high-volume surgeons, and lists these impressive continence and potency outcomes, which of course mentions that the source is the surgeons. And this just illustrates, I think, why in radical prostatectomy and much of surgical outcomes, we have a lack of standardized reporting with patient-reported quality of life instruments, and most of the outcomes, unfortunately, come from the surgeons themselves. Now, Dr. Walsh, as you saw on the earlier slide, was the chairman at Johns Hopkins for 30 years, who described nerve sparing, and in this autobiography listed 27 observations or technical modifications that he made over 25 years that led to his better outcomes. In contrast, when you look at the syllabus for Da Vinci training, and the FDA mandates a 2-day course, you can see that there's dry lab courses being taught, there's of course some simulation, and of course lunch is bold-faced and capitalized here almost as the most important activity. So you can see that a 2-day course in this technique, of course, is going to have some downfalls, such as an expensive learning curve. And the Wall Street Journal, of course, in 2010, talked about the surgical robot and injuries in gynecological as well as prostate surgery, I think likely due to this very long learning curve, as I'll show you later, and the complications that resulted. When we looked at our own personal series, you can see that the blood loss, again, the factor of the technology of the insufflation pressure helped to lower the blood loss as compared to open surgery. However, when you looked at operative time, really the nadir occurred after 700 cases. Of course, operative time and blood loss aren't the most important outcomes for patients. They of course most men who have the surgery want potency preservation. However, I will submit to you that nerve sparing means different things to different surgeons, and that it is a very heterogeneous technique. Not only do you have to be in the right plane to spare the nerve, you have to minimize the amount of trauma that you're inflicting on these nerves. And when I looked at our outcomes in a learning curve for preservation of sexual function using a validated quality of life index, this actually, the plateau for preservation of sexual function took more than 750 cases. Now, when we look at population-based outcomes, of course, Marty Sanda, through his ProsQA, showed very nicely at 6 high-volume centers amongst 48 different surgeons, the difference between a nerve-sparing approach for sexual function versus non-nerve-sparing. However, again, I mentioned to you that this is an averaged outcome of all surgeons in this study, and Andrew Vickers from Memorial has showed very nicely the heterogeneity in outcomes when you look at individual surgeons. This was a study of 11 surgeons looking at the likelihood of recovery of erectile function, urinary function, and then composite functional outcomes in terms of cancer control on the left and functional recovery on the right. And you can see how at a high-volume center like Memorial, there is significant variation in the likelihood of recovery of continence, potency, as well as cancer control. And so these are the limitations that I think preclude using randomized controlled trials as a study design in surgery. Not only that, but in the instance of robotic surgery, the horse is already out of the barn. So in contrast to medical therapies where, and again, I'm not an internist, so I don't mean to belittle randomized controlled trials, but we don't have a standardized dosage of medicine to compare medicine A versus B or a placebo, and the heterogeneity in surgical technique and outcomes often is larger than the difference in the new technologies that are being adopted. So the question, if one were to apply randomized controlled trial, at what point along the surgeon's experience would the randomized controlled trial be adopted? If you saw the learning curve for operative time, that randomized controlled trial early in the experience is going to show better outcomes for the robot, but now in the hands of many experienced surgeons, operative time is actually less for robotic versus open surgery. So then when we look at observational studies to give us population-based outcomes and averages similar to Marty Sanda's study, we of course looked at comparative effectiveness using SEER Medicare data, and we found that there were benefits of the minimally invasive approach. In this case, robotics comprised the majority of the minimally invasive, but this was lumped together as being both robotic and laparoscopic. There was a shorter length of stay. There was a significantly lower likelihood of needing blood transfusions. There were fewer respiratory, miscellaneous surgical, and anastomotic stricture complications. However, the genitourinary rate complication was higher, and when we looked at the use of cystography or X-ray tests to determine whether or not there were anastomotic leaks, this was done 3 times more frequently for robotic versus open surgery. I think that speaks a little bit to the learning curve effects that we talked about in terms of adoption of robotics. I think most controversial and why I think I became somewhat ostracized from the robotic surgery community was the finding that incontinence and erectile dysfunction were more frequently diagnosed. But one has to think about the limitations of claim study to examine these patient-centered outcomes in the sense that, for instance, with the wide marketing of robotic surgery, it wouldn't be unexpected that there's patient selection in choosing robot surgery thinking that there were better outcomes. Medicare, of course, is based on beneficiaries 65 years and older, so a significant proportion of these men already have some degree of erectile dysfunction. And as we showed when we looked at MedStat data, looking at outpatient prescription utilization, you can see that for minimally invasive radical prostatectomy after surgery compared to open, there's much higher use of phosphodiesterase inhibitors such as Viagra, Cialis, or Levitra for potency preservation. And so in order to get the medication, patients had to be seen, therefore diagnosed with ED, in order to get the prescription. So when we look at the limitations of doing comparative effectiveness research with data sets such as SEER Medicare, there's absence of granularity, particularly about the surgeon. Although surgeon volume is a rough proxy, as you saw from Memorial, there's a lot of high volume surgeons that have subpar outcomes compared to their peers. Absence of patient-reported outcomes and, of course, absence of PSA recurrence. And so Lawrence Klotz, who's, of course, known for active surveillance, talked about, editorialized about robotic surgery. Is it early bird gets the worm or is it fools rush in? And he mentioned that and this is data from the American Board of Urology, where urologists typically perform less than 10 radical prostatectomies a year. He thought that in Canada, a few robots should be purchased by acknowledged centers of excellence. Therefore, these surgeons would quickly develop expertise that then could go on to mentor others. And then, again, further dispersion should await solid evidence coming from these centers of excellence. Atul Gawande has talked about surgeons needing coaches. Of course, Dr. Schnipper mentioned that most physicians are mildly competitive, however, surgeons are very competitive. Collaborative feedback has been used as a mechanism to improve outcomes among surgeons. This is just a study from JAMA that showed a reduction in inpatient mortality. And again, in a HMO system where there isn't eat what you treat or a fee-for-service system, you can see that mentoring of others has led to rapid and safe adoption of robotic surgery. Vickers also showed that through online collection of better data, there can be a performance feedback. And so I'll conclude by saying that the opportunities really for policy to improve surgical costs, we need entry of competitors to offset monopolies. As you've seen recently with the litigation of Apple versus Samsung, there's going to be difficulties in terms of patents and entry of new competitors to the marketplace. There needs to be regionalization of new technologies, as Dr. Klotz eloquently argued for. You saw some of the misleading direct-to-consumer advertising that's out there. Surgeon collaborative feedback, certainly a mechanism to improve outcomes for all surgeries. And I do think that health plans should be more involved with providing literacy tests prior to paying for health care in the sense that having their beneficiaries pass these tests to understand the benefits and limitations of new technology. We need to encourage high-growth, high-cost hospitals to behave like low-growth, low-cost hospitals. And I do think that an accountable care organization or ration care is going to drive within departments of surgery patients to those who have the best outcomes and the lowest cost of care. Thank you for your attention.
Last but not least, Jen Temel from MGH is going to talk about some interesting observations emerging from her work that relates to the overlap of the oncologist and the palliative care context. We are running a bit late, as is obvious, but we'll try to retain some time for the panel to entertain questions, if it's okay with you.
Thank you. Thanks, everybody. So I'm going to talk about the role of novel models of supportive care to try to improve quality of cancer care and decrease resource utilization. I actually have a number of data slides that I can summarize rather than going through some of the specifics of the data, but I will flip through the slides if you want to read along. So why should we be thinking about novel models of supportive care for patients with advanced cancer in the first place? Well, the number one reason is that these patients and their families experience a great deal of distress and suffering surrounding their cancer diagnosis. Obviously, the patients have physical distress, and both patients and their families have psychological distress and suffering related to their illness.
I won't spend much time talking about that today, because I think what's a more important issue for the nature of this talk is really the link between illness and prognostic understanding and decision making. Deb referred to some of this data earlier, that patients with serious illnesses, including advanced cancer, often have a limited and inaccurate view of their prognosis and their illness, which may impact decisions that they make about their care and at the end of life, and lead to potentially intensive and futile care at the end of life. So again, I'll just comment one slide about palliative and supportive care for patients with advanced cancer. Really, the take-home point of this slide is that it is hardly ever acceptable or sufficient to rely on cancer-directed therapy to support patients with their physical symptoms and their psychological symptoms with their illness. So any novel model of supportive care really has to focus on providing better support for patients and families. So moving on to illness and prognostic understanding. Multiple studies have demonstrated that patients with serious illnesses, including advanced cancer, want information about their cancer. They want to know what to expect about their illness, and to some extent want to be prepared for death. This is just one such study of almost 400 cancer patients. And what you can see on the right side of the panel is that the majority of patients wanted to be informed the truth about their illness. So certainly there's some variability, and patients want to negotiate what information they're given, how they want this information, the content. But the take-home message from this and other studies is that patients with serious illness desire prognostic information. And the reality is we don't disclose prognostic information to them. In sum, what this study showed is not only do we sort of truly in ourselves portray an overly optimistic prognosis for the patients, but we even communicate to them a more overly optimistic prognosis. And one of the reasons why clinicians have been afraid to disclose prognosis to their patients is that we're afraid that we're going to cause them harm. We're going to make them feel distressed or worried, or may even shorten their life by making them depressed. And we actually have data from Holly Perguson and Alexi Wright from the Coping with Cancer study that that is not the case, that patients who engage in end-of-life care discussions are no more likely to feel worried or sad or distressed. Nonetheless, you might still say, well, those conversations are really hard, they're time-consuming, the patient cries, I feel bad. What's the problem with patients with advanced cancer walking around thinking they have 2 years to live when most patients only live 10 months? Well, there is a major problem with that, because how patients perceive their illness and prognosis impacts decisions that they make about their care. And this has been known going back to the support study, where patients who overestimated their chance of survival were 2.5 times more likely to receive intensive or life-extending therapy. And as everyone in this room knows, they live no longer than the patients who didn't. And even more recently, the CanCor study that Deb referred to, patients who overestimated their chance of survival, and the overwhelming majority of patients did, were significantly less likely to have discussed hospice care. So all of this is leading to what we're here to discuss today, that care is becoming more intensive or aggressive near the end of life. Patients are spending more time in the emergency room, more time in the hospital, and getting chemotherapy closer to the end of life. This slide is really easy to summarize without looking at the data. Aggressive care near the end of life is just bad. It's bad for patients, and it's bad for their family members. Patients who receive intensive or aggressive interventions near the end of life have a worse quality of death, as reported by both their professional and family caregivers. And caregivers of patients who have an aggressive end-of-life experience are more likely to have psychological distress. Clearly, as has been the big topic today, aggressive care near the end of life is also costly. Intensive care unit stays, prolonged hospitalizations, certainly chemotherapy at the end of life, all contribute to the cost of cancer care at the end of life. And again, this is the same Coping with Cancer data that I mentioned a couple of minutes ago, looking at patients who said, yes, they had engaged in an end-of-life care discussion with their physician versus those who didn't. And the patients who engaged in end-of-life care conversations with their physicians were less likely to receive intensive care at the end of life. And this did correspond to a cost savings of approximately $1,000 per patient. So what data is there that we can alter models of care to decrease the cost of care at the end of life? I'm sure everyone in this room is familiar with Sean Morrison's study looking at inpatient palliative care consults and the impact it has on cost of care, either for patients who were admitted to the hospital and discharged or patients who died in the hospital, the range of a couple of $1,000s. So this is a really important study. Clearly, inpatient palliative care consults have a huge role of helping hospitalized patients, but I would argue to some extent, once the patient's hospitalized, the cat's kind of already out of the bag. Many of them, this could have been their third or fourth hospitalization, and they've already gotten costly and potentially poor quality care up until their hospitalization. So I would argue that when trying to design supportive care interventions to improve quality of care, again, focusing on the quality of life of the patient and their family, and also trying to minimize resource utilization, is that we need to focus on interventions in the ambulatory care setting to, again, prevent hospitalizations, frequent emergency room visits. It's been a big topic of discussion today, but I agree with Deb and a couple of others that as we are developing more novel and less toxic oral chemotherapies, chemotherapy closer to the end of life is here to stay. So thinking about interventions to lead to earlier referral to hospice when patients can't get these new oral drugs is probably not going to be an effective strategy for improving supportive care. And again, clearly we need to focus on improving quality of life of patients and their families and try to enhance communication to provide more appropriate care at the end of life. So in thinking about supportive care interventions or models of care, we can think about either targeting the patient and the family or the clinician or the entire sort of model of care. And one such model of care is integrating palliative and oncology care. So as opposed to the model that Sean looked at, where patients received inpatient palliative care consults, which is the traditional way palliative care was provided, can we have palliative care involved in patients with serious and life-threatening illnesses at the time of diagnosis and provide concurrent care throughout the course of illness? So we performed a study in patients with metastatic lung cancer, since I'm a thoracic oncologist. We enrolled 150 patients with newly diagnosed metastatic non-small cell lung cancer and randomized them to early palliative care integrated with standard oncology care or standard oncology care alone. I'm just going to spend a couple of minutes going through our palliative care model because by adding another service on top of their oncology service, we're certainly increasing costs. So in our palliative care study, the care was provided by physicians and nurse practitioners. The visits were scheduled a minimum of every 3 weeks, although many patients would see the palliative care provider every time that they were in the cancer center. The visits occurred within the cancer center. Our palliative care clinic is embedded actually within our thoracic oncology clinic. And these visits either occurred in tandem, so the oncologist would see them first, and then the palliative care clinician would go in, or vice versa. And a large proportion of the visits were actually conducted simultaneously. If patients were admitted to the hospital during the study period and were assigned to early palliative care, they were also seen in the inpatient setting by the palliative care team. So I would argue that the early palliative care model really impacts the whole healthcare system and is truly a novel model of care rather than an intervention because it targets the patient and the family and the oncology clinician. We collected a number of both patient and family caregiver reported outcomes, including illness understanding, which I'll get to. And we also looked at resource utilization, chemotherapy administration, hospice, location of death, and also hospitalizations and emergency room visits. So this data is a little bit less exciting after Deb showed similar data, but this is the baseline perceptions of prognosis and goals of treatment. So what's really fascinating about this is patients did this baseline data immediately after signing the consent form for the study, which says 7 times that they have incurable disease and that they're enrolling on a palliative care study. Immediately afterwards, they checked these boxes, and you can see, similar to the CanCourse data, a third of patients thought their cancer was curable, and almost 70% thought a goal of therapy is to get rid of all of their cancer. For those of you in the room who are not thoracic oncologists, the complete response rate to chemotherapy is 0. So this was our primary outcome measures, which I won't spend a lot of time on. Early palliative care improved patients' quality of life and also led to lower rates of depression on 2 of the scales included on this slide. So getting back to this issue of illness and prognostic understanding, so as I mentioned, a third of patients at baseline believed their cancer to be curable. Did involvement of palliative care, did changing the model of care with the oncologist and the patient alter illness and prognostic understanding? Well, actually, it appears that it did. So patients receiving palliative care were more likely to remain or become accurate in correctly stating that their cancer was incurable over time, as opposed to patients receiving standard care who are more likely to remain or become inaccurate in reporting that their cancer is curable. So somehow this new model of care was able to alter patients' understanding of their illness and prognosis. And whether that was directly with the patient or an impact that the palliative care team had on the oncologist is not clear. Well, what about resource utilization? So chemotherapy utilization over the course of illness was not different. And specifically, we looked at that because there was a question when the paper came out of whether palliative care enabled people to get more chemotherapy, and that's what led to the survival benefit that we saw, and that does not seem to be the case. But where we see difference in chemotherapy administration is at the end of life. So when you look at the weeks to months before death, there was a difference, with patients receiving early palliative care significantly less likely to receive chemotherapy at the end of life compared to patients receiving standard care. Similarly, length of stay on hospice was longer. So actually referrals to hospice were the same on both arms, as was location of death at home, but our hospice referral rates and death at home rate is actually quite high. But where we saw differences was on length of stay on hospice. So for patients who were receiving early palliative care, the median length of stay was 24 days versus 9.5 days, and that was significant. We also saw less hospitalizations and emergency room visits for patients receiving palliative care. So did less chemotherapy at the end of life and longer length of stay on hospice and decreased hospital visits lead to cost savings? So it appears that it did, at least looking only at the last 30 days of life. This was a big study. These patients lived a long time. Trying to look at costs over multiple patients' entire lifespan in the inpatient and outpatient setting is a little bit tricky, but we've at least looked at the cost data for the last 30 days of life. And you can see that there was a cost difference between early palliative care and standard care, with an average cost difference in the last month of life of about $2,000, which sort of looks favorable when we talk about Holly Ferguson's study that I just showed. Now, clearly, the patients did seem to live a little bit longer, so we will have to wait for the entire cost over the entire life. Not surprisingly, when we drill down on the categories where there was cost savings, it was in inpatient visits because of less hospitalizations and emergency room visits and less chemotherapy at the end of life. So are there other interventions or models of care that we can use to increase discussions between clinicians and patients about end-of-life care preferences and hopefully educate patients so they make better decisions about their care? So another mechanism to do that is targeting clinicians, and Tom Smith's been quoted all day, so I'll just be the last one to do it. I read this paper all the time, and the first sentence is my favorite. We also drive up costs and provide poorer care as a result of what we fail to do, engage in discussions about the possibility of death and end-of-life choices. So we've been doing some work to ask whether we can alter oncologist behavior to initiate end-of-life care discussions, and this is work that's actually funded by the American Cancer Society. And we used academic detailing to try to change oncologist behavior so that they would initiate discussions about end-of-life care preferences more frequently and document discussions in the medical record. I'll skip through this a little bit quickly, but we did focus groups to try to figure out what would be the best way to remind the oncologist to have these conversations. And basically we sent emails that were tied to progression of disease, so tied to new lines of care of chemotherapy to remind the clinicians to initiate these discussions. And what we found is on the top line there, compared to historical controls, clinicians who received the email prompts or reminders to initiate conversations about end-of-life care were 3 times more likely to document a code status in the ambulatory care setting compared to historical controls. So palliative care workforce issues are significant. As actually Deb pointed out earlier, do we want to share all our patients with palliative care? Maybe not. So I think it's really important to think about interventions focused on oncologists that can also do some of these tasks that the palliative care clinicians were doing. So I think this is one mechanism of data that we can change oncologist behavior to initiate these conversations. Well, what about targeting patients? Even when clinicians have discussions about resuscitation preferences, they're often ineffective due to poor communication. And the reality is even though we try to describe CPR and intubation to patients, they just don't have the knowledge or experience to be able to make good decisions about them. So there's an investigator at Mass General, Dr. Angelo Volandes, who's developed videos with imagery to help patients better understand some of the interventions that we're talking about when we discuss their end-of-life care preferences. And he's completed a study of 150 advanced cancer patients who were randomized to either the video description of CPR or a verbal description where a research assistant just read out what CPR entailed. Compared to patients who received the verbal description, patients who watched the video were significantly more likely to state that they would not want CPR, and this was a significant finding. Similarly, patients who watched the video were more likely to answer questions about CPR accurately, including definition of CPR, chance of survival, complications, and chance of leaving the hospital after CPR. So again, what this shows us is targeting patients, educating them so that they can make more informed decisions about their care is also a viable model to study further. So in summary, novel models of care targeting healthcare delivery systems, clinicians, and patients can alter patterns of care to decrease resource utilization, increase rates of end-of-life care discussion and documentation, and enhance patients' perceptions and knowledge regarding interventions on the end of life, and further research to investigate the impact of these interventions on cost of cancer care is warranted. Thank you.
I just wanted to let everyone know that we're having a reception at the end of this on the third floor in the atrium where everyone is welcome. So if you're worried about the time and we're late, but we'd still like to have a little bit of a panel discussion, the National Cancer Policy Forum is inviting you all to join us upstairs. So I hope maybe we can have at least 15 minutes of discussion, and we will have opportunities tomorrow to discuss many of these issues. So.
Well, thanks, Patty. Can we have the speakers just join us up front and ask those of you who might have some questions for any member of the panel to come forward? Yes.
Tom Feely from MD Anderson Cancer Center. So I want to thank the entire panel because this was very instructive. I'd like to ask the Death Star folks, proton therapy and robotics, and I'll just say by a disclaimer, I'm an anesthesiologist, I'm not an oncologist, but I've been involved in critical care and anesthesiology for nearly 40 years, and I've watched the introduction of life support treatment being applied to cancer patients. I've seen all of these things come into our existence without a lot of evidence of how well they work. And I'm not going to want to debate all of the existing things. My question is, for the future, how should we evaluate new expensive technologies when the next Death Star comes along, when the next intraoperative MRI super robot comes along? How do we, as a healthcare system, evaluate those new technologies, those next stage technologies, to better understand when are we looking at an intervention that is absolutely critical for our patients, or when is another one that is just going to break the piggy bank?
Jim, why don't you just start off?
Sure. So I think I would look at what I presented in terms of what Dr. Klotz's comment was in terms of having acknowledged high volume centers of excellence, particularly in surgery, where there's going to be definite experience and good technical technique to evaluate whether or not new technology should be disseminated. So again, very few centers in the country, 3 or 4. The device manufacturer sets up shop there, no relationships at all with the investigators, of course, and then look at this closely. I think that is really the only mechanism to prevent the widespread rapid adoption of these untested technologies.
Justin.
I would put it into 2 different frameworks. One is a regulatory framework and the other is a market-based framework. In the regulatory framework, I think we can talk about coverage with evidence development. The issue with coverage with evidence development is every time I've spoken to the folks at CMS about it, it's a very blunt instrument, and they're very loath to actually use it. And so we talk about it a lot at these forums, but because it's a regulatory framework, it's a very blunt instrument and is probably not appropriate for most technologies. The market-based framework, I think, has advantages. And so if we move to a global payment system, vendors are going to become aware very acutely that they can no longer sell the bells and whistles without the evidence to show that they're improving value. And so that market-based signaling is going to compel the vendors to begin to demonstrate the evidence of the therapies, even as part of FDA approval. And the FDA approval has to be beyond the typical 510K process that's right now. It has to be, and I'm not suggesting that there should be more regulatory aspects of the 510K process, but I am suggesting that vendors are going to find it very much in their interest in terms of increasing shareholder value to begin to demonstrate the evidence of their products. And the next type of therapy that is coming down the line is, in my field, carbon ion therapy. Carbon ion therapy is in Japan. It sounds very science fiction, but it's being used for the treatment of cancer in Japan, and there are many facilities that are considering that treatment today here in the United States.
Let's switch to the other side of the room.
This is Barry Kramer, the National Cancer Institute. I think I heard two very different perspectives from the radiation oncologist and the surgeon as follows. Dr. Bekelman reported that, if I understood him correctly, he wanted to do a randomized controlled trial and ran into serious headwind because of different perspectives from science regulatory agency or a scientific agency. And I think I heard Dr. Hu argue against doing a randomized trial of two different procedures, and he likened it, I've heard this analogy many times before, likened it to doing a randomized trial with parachutes. And of course that would be true if the height were from the Empire State Building. But many times I think we may be overselling the case and thinking we're at Empire State Building height when we're actually just jumping from the first floor, where there may be dangers inherent in jumping, using a parachute to jump out of the first floor, get tangled up, get strangled, break a leg, so forth. And there have been some very rude surprises through medical history and surgical procedures when we have assumed we're jumping from the Empire State Building and found out it was a first floor jump, if that. For example, radical mastectomy versus lumpectomy, radical prostatectomy versus nothing in the pivot trial. I think we were a bit surprised at the magnitude of the benefit. No statistically significant difference, and the upper bound on the 95% confidence interval was about 2.9%. I don't think we assumed that we were jumping from the first floor. Knee surgery. There was a lot of resistance to doing knee surgery, and we found out that doing sham surgery versus full court press knee surgery was no different, and back surgery, again, is a controversy. So my comment is that we often don't know, and there'd be no argument, by the way, when, in the beginning, when you have a highly effective therapy, I mean, a home run, truly a home run, testicular cancer therapy, cure rate goes from a few percent to 75, 80, 85% higher. You don't need a randomized trial. The first antibiotic to treat pneumonia, don't need a randomized trial. But once you've made that initial huge increment and you're comparing shades of differences, I think that a randomized trial may be the most efficient way and subject to the fewest confounders. And I think trying to rely on epi evidence opens up the study design to a far larger range of confounding factors.
So if I...
Put your mic on, Jim.
There we
There
go.
you go.
So I would just comment real quickly about the pivot trial being underpowered, as many have noted, with the recruitment of 734 patients versus 1,200. And if you look at the randomized controlled trials, I know we've talked about PSA screening, and as a urologist, I readily acknowledge that we overscreen and overtreat prostate cancer. At the same time, when you look at Crawford and D'Amico sub-analysis of the PLCO, and you limit the screening to those with few comorbidities, as well as younger men, the benefit of screening was in those who are aged less than 65. Now, going back to the pivot study, the mean age of that VA-based study was 67 years, and 15% of men had significant impairments in their activities of daily living, yet there was a trend for there to be benefit of surgery in men with high-risk prostate cancer. So again, I think it's saying that we operate too extensively on men with low-risk disease. Finally, with respect to randomized controlled trials, it's not that I'm not a proponent of them in surgery. I think that if you could get Patrick Walsh at his prime to train in robotic surgery, be as good as he is in open surgery, and then have a single surgeon randomized controlled trial or randomized controlled trial amongst acknowledged surgeons who have had third-party collection of their outcomes and therefore validate that they're at the best in their field, then add the component of whatever new technology you're adding, then that would be great. But unfortunately, that's not how current randomized controlled trials of surgery are designed because of the mediocrity oftentimes in these surgeon subjects, I would purport.
Now, so then I think you run into serious problems with generalizability. There isn't one surgeon in the country doing the surgery, there never will be, and what we're talking about is how things play out in the country. And then you've gotten into another murky area, which is screening. That you talked about surgery, but screening is related. The pivot trial, as I said, had an upper bound of difference of 2.9%, not as much as I think we assumed. In the PLCO, I'll just point out that the analysis, the retrospective subset analysis, which is always a problem, which identified in one study that there was a subset that appeared to benefit, that is those with no comorbidity, has been redone, and it turns out that the definition of comorbidity, the result is highly sensitive to the definition of comorbidity, and when more standard definitions are used, that difference disappears.
Let's move on to another questioner, sir.
Yes, thank you. Doug Peterson from University of Connecticut Health Center. And as I'm sure we all realize, there are so many key steps to reducing healthcare costs in this country. And Dr. Temel reminded us that targeting the clinician is one of those many key steps. And so to Dr. Schnipper, may I ask, on the ASCO top 5, and thinking back to Dr. Feinberg's opening remarks this morning on could these kinds of discussions here and after today lead to reforming healthcare costs in general, not just in oncology. My question becomes, for the ASCO top 5, are there other health organizations, health professional organizations that have done similar instructions, if you will, and are there lessons to be learned for the ASCO initiative? Or conversely, could the top 5 approach be a paradigm for reducing healthcare costs in general in this country?
I think to generalize the concept, you ask a very good question. The American Board of Internal Medicine is collaborating with Consumer Reports, and that campaign is called the Choosing Wisely campaign. To date, they've enlisted 9 subspecialties that agreed to identify in each of those specialties commonly used procedures or technologies that add no value. So that is nuclear cardiology, clinical cardiology, radiology, medical oncology. I don't recall every last one. Rheumatology, nephrology, and each of them is required, number one, to develop the metrics, to justify or quantify, I should say, the use of each of their top 5, and then follow up, ideally follow up in a year and a half, to see what impact there is, because each of these organizations have agreed to essentially pick up the mantra and try to prosecute the message to their membership and to the lay public. Consumer Reports essentially sees this as a consumer-based issue. They're teaching their readership to basically question the medical care providers. Is this necessary? Why is it necessary? Et cetera, et cetera. So it is a fairly broad-based initiative, and more subspecialties are signing up. So there's going to be yet another round of specialties doing the very same thing. Now, to what extent this can actually achieve genuine momentum as we sculpt our healthcare system, I'm not sure, but it does put a lot of the key decisions in the hands of those of us who are honored with that responsibility on behalf of our patients. Yes, Otis.
Otis Brawley, Emory University, and the American Cancer Society. I just want to reiterate we need to be careful in using subset analyses to make clinical decisions. They usually should only be used to justify the next prospective randomized clinical trial. With that, Dr. Hu, I wanted to ask you about an issue with the Da Vinci that I worry about, and that is, are we training a generation of surgeons who are afraid to operate? I'm worried that people who learn to use the Da Vinci well, who get into a situation where they need to open the abdomen, are actually afraid to open the abdomen.
That's a great question, Dr. Browley. So the way that I'll answer that question is a quick anecdote. So years ago, of course, at academic medical center, you interview medical students for residency training. 3 years ago, most residents or prospective residents would say, how are we going to get time on the robot? You know, do you have a dual console robot? Now the residents 3 years later say, how are we going to get training in open surgery? Okay, so I think your question is well directed. That said, I would just point to, again, I don't know the how to cure or answer this issue, but there are centers where there are government hospitals, non-VAs, because many VAs have acquired the robot, but there's county hospitals where there is an absence of funding to get these robots, where open surgery continues to predominate. But I agree with you that there is going to be a generation of surgeons where you need someone who was trained in a third world country that knows open surgery to be hired onto the staff, and you kind of break in case of fire, so to speak. So I think your question is very well directed.
Yes, Stephen Taplin, National Cancer Institute. One comment and one question. Comment is that it's a common misperception that when a review sends back comments on a grant application, that's a statement from the NCI. It isn't. It was your peers that were confused about the conflict of interest, and so that's right. So it's a common misperception, and it's a common problem. Second question is really to Deb Temel. That the question here is about the quality of life. Jennifer Temel. I'm sorry, Jennifer Temel. So the question about quality of life. So in giving people information at the beginning, clearly the question is how good is their life after it. And you've addressed what happens at the end of life. Did you have measures of quality of life while they were alive, and whether, in fact, informing them about their survival or the end of their life helped them during their life?
So in the Coping with Cancer study that I referred to, where they just looked at patients who had end-of-life care discussions or not, that was sort of one snapshot in time. It was the patient's recall of that. For us, for the early palliative care study, the illness and prognostic understanding questions were given over time at 6, 12, 18, and 24 weeks, and people sort of changed their perception of their illness at different points in that time. So I would say that the majority of patients who either became accurate in stating that their cancer was incurable was at the 12 to 18 week mark, and that is when we showed an improvement of quality of life. But with respect to a time course of those conversations and how quality of life changed, we don't have that data.
Thank you.
Tom?
Tom Smith from Hopkins. Just have a question for Dr. Bekelman about making the case that not using single fraction radiation therapy is really an issue of professionalism. I came from an institution that did it routinely, and we did it across rural Virginia, and it was really a wonderful thing to be able to treat people once or simulate them and treat them even on the same day. And now at Hopkins, that's not the usual mode, and I've been on a real mission for the past year to convince the radiation therapists to do single fraction radiation therapy. And actually making some inroads. You've seen 10 fractions go to 5, 5 fractions go to 2, and even occasionally 1 for uncomplicated bone metastases, where it's clearly ASTRO's own guideline. But one of the wonderful things about radiation therapy is you have a daily conference where you review people's care plans, or at most a biweekly conference. And what would happen if at each of the institutions represented at the table, you appointed somebody to be the single fraction proponent? And your job, when somebody who had an uncomplicated bone metastasis was proposed anything other than single fraction radiation therapy, would be to speed dial the chief medical officer of the hospital
Ding.
Ding. You could even use the bell that you'd have it when you finish your radiation therapy to ding. No, so you call the chief medical officer and report to her that, in fact, we had an opportunity to do really good care with a single fraction, but we didn't do it. I'm using this as an example to illustrate how uncomfortable this makes us feel. I know it's made me uncomfortable proposing this with my radiation oncology colleagues. I suspect it would make you uncomfortable telling your radiation therapy colleagues that they're doing something wrong as well. So how would you propose that we change as a country this one simple thing that's well-versed in multiple randomized clinical trials, not just one?
First, here. Absolutely. So there are several issues here. While I think that reimbursement is part of this puzzle, I don't think it's actually the main part of the puzzle. In fact, when patients are in the hospital, there is no specific radiation reimbursement. It's all radiation becomes part of the bundle. So radiation is part of the puzzle, but it's small. When I talk to very senior clinicians, they have anchored on 10 fractions. And they won't go to one fraction because in their experience, which we respect, they believe that 10 fractions is required and will avoid toxicity for the patients. And they're thinking about the patients. They couldn't care less about the money. And then when I go to the young docs and I ask them, why don't you do it? They say, well, because that doctor trained me. And because he or she does 10 fractions, I do 10 fractions. And so this all has to do with training and the culture of medicine and the anchoring that we all do around clinical care. And so the intervention you're describing is a physician-led intervention. And we can think about any several types of interventions. But in my view, the way that we would pilot this is around either a physician-led intervention with payment reform or a payer-led intervention with payment reform and a clinical care pathway.
Can I add one thing to that, Tom? So you've mentioned in the very beginning of your statement about this issue of professionalism. And when we think about 1 versus 10, we're sort of asking a fairly dichotomous question. But the other part of that professionalism is how we're taught when to make the decision to discontinue something. And Deb brought up the example of the patient showing up with multiple months of sorafenib and really only taking two weeks of therapy. But really, my point here is that part of our professionalism is to say, here's the outcome we're looking for together, and here's how we're going to benchmark to that outcome. And if and when we do or do not achieve it, that's how we're going to make some decisions about going forward. And this need to find an intervention, but also a need to figure out what's the outcome we're trying to do is an important part of our professionalism. We're studying right now this question of continuing versus discontinuing statins for people who are in the last year of life. And we actually have no data to make decisions about how to simplify the medicines that we've given patients. We've got the same problem when we enter them into the ICU, or we try and decide what to do in initiating therapy for chemotherapy. And so I think that the professionalism you're bringing up is part of the professionalism of asking the questions.
I have a question for Deb. She spoke a lot. Deb, you spoke a lot about new drugs, varying degrees of impact. I'm wondering whether or not we have it right in terms of the system we use to approve drugs for clinical use. Specifically, the Food and Drug Administration by statute is charged with judging the scientific evidence and moving on that. It has nothing to do with the impact, at the level of the patient or the healthcare system. Do you think there's any sympathy or rationale for trying to think of a different way of making decisions about when to give a green light to a drug?
Absolutely. The FDA is responsible for applying the efficacy standard. Is there evidence for efficacy? That's it. It's not charged with, by statute, looking at whether something is value. Right. What is the value? CMS is also, unfortunately, by statute, not allowed to consider cost. So it was really quite revolutionary when, with sickle cell, the new prostate cancer drug, they actually allowed carriers, so Medicare administration, Medicare is divided up into different regional-based carriers, and those carriers, because of the just exorbitant costs of sickle cell, they were allowed to consider whether or not and how they would make it available to men, to their covered lives. So, yes, absolutely. I think, the answer is not simple. It's not going to be the same for all drugs. It's very difficult to figure out where to draw that line in the sand. We know it's black, we know it's white, but just exactly where do you draw that? And of course, the evidence base is always changing. So you draw the line and then you learn something new, some marker that predicts, and you have to move it. So it's a Sisyphean task. You're never done. We have to tackle it. Medicare needs to start to consider this, but it's going to require legal changes in our system.
Yep. Lots of luck there. Any other questions for the panelists? If not, thanks very much for your indulgence for staying a bit late.
Just join us in the atrium on the third floor if you want some little bit of refreshment.